Okay, Chair, you have enough for a quorum. You can call the meeting to order whenever you are ready.
Yeah, one more minute to be exact.
Yep.
Don't want anybody complaining I was 30 seconds late. Although if you're 15 seconds late in one state, they couldn't get the name on the ballot of a candidate because they rushed and dashed and were there 15 seconds or something late to get to the door, which is funny. All right, it's 9 a.m. We'll call the meeting to order, basically, and let's have the roll call.
Good morning, everyone. I'll start with our voting commissioners. Dr. Khan,
Present.
Dr. Barron,
Present.
Teresa Bohannon,
So I think,
Bond.
sorry, while we are at Teresa, I think she's the one who requested indicated that she will not be able to join for personal reasons. So let the record show that we did receive in advance information from her.
So
Go ahead.
she's absent, excused.
Yes, she's absent and excused.
Okay. Babette Bond,
Here.
Jessica Flood,
Here.
Flo Khan. Flo here yet? Dr. Packham,
Here.
Yarleni Roa Dugan,
Here.
Sean Shaner,
Here.
Dr. Slonim,
Here.
Mason Van Howling,
Are you on mute, Mason?
I see him on there. He's muted. I'm going to move on to our advisory commission members now. Heather Korbulik,
Here.
Barbara Richardson,
Here.
Richard Whitley.
Here.
That concludes our roll call, and we do have a quorum.
Thank you, Leslie. Appreciate it. We're moving on. Item number 2 on the agenda is a public comment. Do we have any public comment in the north? Leslie, do you see anybody?
Actually, Dr. Khan, I'm so sorry. We went live, but we did not admit anybody into the room. So we just, I think we need to restart and call the meeting to order and just take the roll call again out of an abundance of caution. We just had a technical issue and looks like we're now officially live. I apologize. So.
All right, so we get back to calling the meeting to order and the roll call again. Leslie, please.
All right.
Sorry,
Dr.
guys.
Khan,
Present.
Dr. Barron,
Present.
Teresa Bohannon is absent, excused. We've already gone over that, right? Okay,
Yes.
Babette Bond,
Present.
Jessica Flood,
Here.
is Flo Khan on yet? Not yet. Okay, Dr. Packham,
Here.
Yarleni Roa Dugan,
Present.
Sean Shaner,
Present.
Dr. Slonim,
Here.
Mason Van Howling,
Probably still on mute.
still muted. Yes, I could see. Okay, Heather Korbulik,
Present.
Barbara Richardson,
Here.
Richard Whitley.
Here.
Mr. Chairman, that concludes our roll call and we have a quorum.
Thank you, Leslie. Appreciate it. We can move on to item number 2 for public comment. Anyone up in the north for the public comment?
Sure, hold on. Let's see. Okay, attendees, if you can take a moment right now to raise your hand if you're participating on the phone. I believe you can hit *9 to raise your hand if you're if you've dialed in. We'll take the first person, Bill Welch. Hold on one moment. Let me let Mr. Welch.
So please, a reminder, we have no 3 minutes max for the presentation. So please proceed.
Thank you, Mr. Chair. I'll keep it to 3 minutes. For the record, my name is Bill Welch, President and CEO of the Nevada Hospital Association. I appreciate the opportunity to provide comments related to the direction of bill drafts request being drafted by the Patient Protection Commission. At the August 17, 2020 PPC meeting, I recommended that the third BDR be used to address Nevada's Medicaid or our healthcare workforce needs. At this time, I withdraw my recommendation to include Medicaid, but strongly reaffirm the Nevada Hospital Association's desire to have healthcare workforce addressed as the third BDR. Bill language can be worked on past September 1st. A simple title with aligned descriptive language is all that is needed to secure and file a BDR with the Legislative Counsel Bureau. Work can then be done by the PPC on this healthcare workforce BDR once draft bills on transparency and telehealth have been finalized. Workforce challenge is one of the biggest driving factors affecting access and cost of healthcare, a primary focus this commission has been charged with addressing. Regarding the proposed transparency BDR, the hospital community has great concerns. What is currently being proposed is far-reaching and broad, and we recommend that it is narrowed down to focus on all claims payer database that includes all providers such as payers and other providers which are part of the healthcare continuum. The NHA has provided price and quality transparency information via the internet to the public as far back as 2007, and we continue to provide detailed information on various websites, as does each hospital facility. We don't see comparable options available to patients from others in the healthcare industry, including health insurance providers. All within the healthcare industry should be held accountable to transparency, not just one aspect of the industry. Finally, NHA opposes expanding the authority of the PPC, which is included in the transparency BDR. There are existing state and federal entities that provide direction and oversight and monitor access, cost, quality, and other data. It is not clearly understood how the expanded role of the PPC connects to transparency for patients and provides better healthcare outcomes. Thank you.
Thank you, Mr. Welch. Anybody else in the north?
Okay, it looks
Anyone?
like we have one more person. I'm going to let Mr. Michael Gagnon.
Is he on?
He is. He's on mute though. Mr. Gagnon?
Yeah, can you hear me now?
There you are. Yep.
Very good, thank you. Good morning, commissioners. Michael Gagnon, Executive Director of Healthy Nevada. As a follow-up to my last comments at your meeting on August 17th, I'd like to recommend that you consider using one of your bill drafts to propose changing the state's outmoded opt-in consent law to opt-out. I'd also like to propose a role that the Patient Protection Commission could play to improve the interoperability and oversight of patient data across Nevada. As for the opt-out, I think you heard one set of opinions on the topic of opt-in versus opt-out, but here are some facts that from the data we collect. Nevada is only one of 7 states which remain opt-in. None of them are in the West. Vermont changed earlier this year, and Rhode Island will do so, and we'll be down to 6 states soon that are opt-in. 95% of patients opt in when asked, Nevada and nationwide, that's a statistic. Patient privacy is not improved by making the process more complicated. Those who wish to opt out may still do so. Less than half the patients who have data in the HIE, about 46%, have been asked to opt in. Thus, more than half of the data in the HIE is effectively inaccessible to treating providers today, which seems like a travesty to me. Patient safety is impacted by providers not having access to this data, despite the fact that 95% of patients would opt in. It is administratively complex for providers to collect consent in their offices, and thus most provider offices do not. And it is costly to collect consent on all patients. We estimate that it will cost about $12 million to collect consent on all Nevadans, about $3 per person, while we could only need to collect 5% of those. Moving on. One of the other things I think the Patient Protection Commission could consider is to create a public-private partnership to create and provide oversight to something we call a health data utility. The most common and successful HAs in the country are public-private partnerships. And the state, usually appointed by the governor, appoints a commission to oversee the HIE, and that thing becomes a service for everyone in the state to use. The HIA remains a private nonprofit and operates the HIA within this guidance, and the HIA has its own governing board to manage HIA operations. There are numerous examples of these across the country, including Vermont, New York, Maine, Michigan, Delaware, Rhode Island, Maryland, Massachusetts, Nebraska, Arizona, Wisconsin, New Mexico, and several others. The Patient Protection Commission could potentially play the role to be the public-private partnership oversight board. This could be modeled after other states, such as the Green Mountain Care Board that's done in Vermont. Thank you.
Thank you, Mr. Gavin. Anyone else in the north?
Miss Joan Hall, it looks like you raised your hand. I'm not sure if you wish to speak at this time.
Thank you. Yes, I would, Sarah.
Okay, great.
Thank you. Members of the commission, Joan Hall, representing Nevada Rural Hospital Partners. I appreciate having telehealth as one-year BDRs, but I continue to worry about healthcare workforce. When I presented before you on telehealth, I talked about the difficulty rural hospitals have getting specialists licensed in Nevada to provide telehealth. I think healthcare workforce is the cornerstone to healthcare, and it really impacts patients and patient protection more than anything else I can think of. It impacts our access to care, adequate insurance network, and impacts both quality and cost. In 2019, statewide, Nevada ranked 48 for primary care providers per capita. In the rurals, as you can only imagine, it's much worse than that. But it's not just primary care, it's specialists, and it's behavioral health care providers, it's dentists, dietitians, pharmacists, pre-hospital providers, paramedics, post-hospital CNAs, and home health providers. I served for many years on the governor's workforce development medical sector. We can never crack this nut. I think that this needs and is deserving of a BDR. Thank you.
Thank you. Anybody else in the north?
I don't have anybody else who's raised their hand. I think that concludes public comment in its entirety, Mr. Chairman.
Nobody in the south?
No.
All right, thank you. So move on to item number 3 on the agenda. Presentation from patients about their healthcare experience in Nevada. Do we have any patients who signed up, or are they north or south?
Sure, I don't have anybody who have signed up. If I can take a moment, if anyone who is watching or participating, if you are a patient who wants to provide your testimony, this is the time for you to raise your hand. Please do so now. If you're on the phone, you can press *9. Mr. Chair, I don't see anybody.
All right, thank you. Item number 4 for possible action, approval of August 17, 2020 minutes. They were circulated earlier. Anybody has any comments, additions, subtractions, etc., please let us know now. If not, then I would entertain a motion to approve.
Mr. Chair, this is Mason. No changes or adjustments to the minutes, and I'd make a motion to approve the minutes from our last meeting.
Do we have a second?
This is Tony Sloan. I'll second.
All those in favor, please say aye.
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 Any opposed? Thank you. The motion carries. So the opening remarks by the chairman. So I'll be brief. So I'm hoping that today, if we can narrow down and come to some consensus on this almost final language on the current 2 BDRs that we approved in principle and in general consensus last time. It has gone through some vetting processes preliminarily with the LCB, the AG's office, etc. So my hope and wish and desire is if we can finalize those 2, we would have made great progress. Having said that, there may be a possibility that some of the language in the current 2 preliminary drafts of the BDRs potentially may need to be split into a 3rd one, and we'll talk about it as we go along in our discussion on those 2 BDRs. And then at the end, we will certainly look at the possibilities and various scenarios and technicalities, legalities in submitting a 3rd BDR. If we come to a consensus, what are our options? And I would then request the AG's office and Sarah to chime in when we get to that. But if we can initially focus on the 2 BDRs and hopefully get them out of the way, so we would have accomplished a lot given our deadlines moving forward. And we can certainly discuss the 3rd one, if at all we can manage to get a consensus and make sure that the technical logistical issues are addressed by the AG and other office regarding those possibilities. So again, my hope is if we can all focus on the issues specifically in front of us, and if we all don't get distracted during these 2 BDR discussions, we'll have time after the BDRs are hopefully finalized in the final draft form to then discuss the rest of the issues that are on our minds. And there are quite a few during my exchanges with several of you. Having said that, that's all I need to say for the opening remarks. I would move on to the next item, update on collaboration and coordination between the Commission and other state entities. Sarah, you have a presentation.
Yep. Thank you, Mr. Chairman. I'll take a brief moment. I would like to just give the Commission a quick update on some of the collaboration efforts. Most notably, the Clark Regional Behavioral Board invited me to come and join their last meeting. They had to reschedule theirs until September, but they are moving forward with a bill draft themselves related to mental and behavioral health. One of those components that they talked about is related to transparency. So in an effort to coordinate efforts and not be duplicative in nature, they wanted to hear from the Commission as to what we are doing. So that meeting has been postponed. I anticipate meeting with them when it gets rescheduled in September to give them an update on our work. I also want you to know I've spoken to the Washoe Regional Board. They are doing a BDR around substance abuse. The Rural Board, I believe, is doing a BDR around licensure and reciprocity. I don't know the details of that, but I do know that that is one topic area that I believe that they are pursuing. The Northern Board, which our Commissioner Jessica Flood is on, is submitting a bill draft around mental health. And another thing that I want to make sure everybody is aware of is the Legislative Committee on Healthcare. They will be holding their final work session next month, September 14th, as well as the interim study on cost of prescription drugs. They're holding their work session on September 8th. And last update I'd like to tell all of you is I've connected with Senator Spearman. As many of you may know, she had a bill draft last legislative session to establish an all-payer claims database. So out of courtesy, I reached out to her to let her know that this is one of the components in your transparency BDR. She indicated that she is enthusiastic that this commission is taking that on, and she would like to continue to be a part of that discussion moving forward and looks forward to working with us in session. So that concludes my update, and I'm happy to take any questions or elaborate further.
So any question for Sarah on this comment? If not,
Dr. Khan,
yes, go ahead.
I was just going to add, it's my understanding there's a
Please identify yourself for the record.
John Packham for the record. It's my understanding that there's a study underway right now. Maybe Heather or Richard could comment on a study, Bill, that came out of the last session on the public option. And I think it would be important for our group between now and January to be updated on that. And I don't know who would do that, but I think it bears on access and affordability.
All right, thank you. Any other comments before we move to the next item?
Mr. Chair, it's Tony Sloan. Just a question, and thank you, Sarah, for your leadership on this, collaborating with others in the state. Given the limited conversations we've had here as a commission on either mental health or drug abuse addiction, I'm trying to understand in what way we might be advocating as a commission, given the limited conversations we've had. It's not like we've gone into depth about what we actually represent as a commission. So I'm trying to understand what kind of things will be discussed.
Thank you, Dr. Sloan.
Go ahead.
Sure. So I think that's your prerogative and how you would like to engage and maybe put forth in front of this commission. The intent of my collaboration with others is just to make sure that we share what we're doing with what they're doing. And I'd like to just make sure that everybody is aware of these efforts. So if there's something that comes up that I think might be of interest to this commission, I just want to make sure you are all aware of it. Certainly, I think the folks on this commission have their own conversations about issues that you think might be within the jurisdiction of this commission, so you can bring it up. I just wanted to take an opportunity to make sure that everybody was publicly aware that I've had these conversations, this is what they're working on, and then kind of inviting the commission to take a deeper dive if that's what you would like to do. And if you'd like to invite them or have a meeting with them to discuss that, then that's your prerogative. You can bring it back in front of this commission. And then if anyone reaches out to me, this is the place in which I'd like to share that update too.
So a quick comment on that. My personal view on this is that there are a lot of other departments, agencies, individuals, legislators addressing various subjects that we have talked about. And some are in relatively advanced stage, either considering a BDR, et cetera, et cetera. So I think it's important for us as a commission, as much as we have on our plate, to see what is being pursued and not duplicate the efforts already in works, which are, if they are moving in the right direction, the direction that we would have liked to do as a commission. We can certainly reinforce that, in my opinion. And as Sarah mentioned, perhaps collaborate with them if they need an added weight of the commission at some point. So the important thing is to avoid a duplication of efforts and on the subjects, various, for example, the mental health and license reciprocity, etc. If there are others seriously considering that to proceed at the legislative level, then I think if we were able to just reinforce that as a commission, since they have been a subject of discussion in our meetings in the past, then that would help us to focus on the other subjects which are not being addressed necessarily at this upcoming legislation to proceed as BDRs, etc. That'll streamline us a little bit and make it more efficient to function on areas that are not being addressed currently in a significant way to proceed with the legislative level. Any other comments?
This is Tony Sloan. Just one follow-up comment. Thank you, Chair Khan, for that. My reason for the inquiry is there's obviously important work that we have to do, and we should, through the legislative process, drive all levels of efficiency. My question had to do with how staff was going to represent this commission with only superficial conversations that we've had on the topics of mental health and addiction. No doubt a priority area for the state, for access, for workforce, for telehealth, for transparency. And we've only scratched the surface in our conversations. And so I want to be understanding a little bit about how those conversations are being represented when we've only had I yearn for more conversations on those topics because they're so important, but they should represent the input of the commission as a body at some detailed level, like we've done with the 2 BDRs on transparency and telehealth.
So John, I agree with you. So my thought on that is, Sarah, if we get some of the languages or the subject being addressed by the other entities or individuals in the legislature, if we can get those languages, so some in future meetings, once we have them, we use that as a basis or foundation to add to it based on our own perspective as a commission to give more strength to that approach. But if we have that available to us, then it gives us a baseline structure to expand on and elaborate and put our input and see if they're willing to, address that and add on to their approach. Does that make sense?
Yes. And also to both of your points, I think that we could also do the same with our commission. So when the language comes out, instead of us having these vague ideas of what we're doing, it would be great to put our language out prior to November 18th deadline to really make sure, I mean, the devil's in the details, and with all of these people in the same arena, I think that it would be great to get full input from everyone. And also, once we get our language for our BDRs, I would request that we do have stakeholder education materials developed so that we can come out and really be able to be clear on the changes that we're making. In the Northern Board, we are tackling mental health crisis hold law. It's super complex. And a huge part of what we do is developing that stakeholder education material so that no one's confused and we're all on the same page on this.
Thank you.
To that question, I just have a quick question. So when we get the BDR language, I think that's when we're really going to understand what's happening. We'll have a meeting prior to actually the submission of the BDRs to approve the language, correct? Like a work session?
Sarah, you have a comment on that based on what has been advised?
Sure. I think that you have a couple different options. Again, this commission is new, and how we're working together and what we're doing is really kind of at our discretion as a group. And so if you would like to call a meeting to order once language is available, that's certainly an option that you can consider. I would defer to your judgment on that, Chair Khan, if that's something you'd like to do. And maybe that's a conversation that you have later on in the agenda around your future meetings and discussions. Going back to Dr. Sloanum's comment, I think I'm not sure if I understand your question entirely. I think you were asking about the process in which we engage with others. And what I would like to say is when I talk to any person, whether it's a legislator, commission, and I represent this commission, I remind them of our work that we're doing. And I always defer to the commission's work in our public records or our minutes, and then reminding them about what's in our jurisdiction, what's our mission, and what the goals are. So I don't speak on behalf of the commission's position. I think that that's what you're alluding to. But I'm not really sure if that's where your question was going.
Yeah, so there actually is not a lot on addiction or mental health that are in the publicly available documents or the minutes. So that's why I raised the question. I want to go back to something that Commissioner Flood said. I would be imploring this body to review and approve after the LCB looks at our language and has provided input, the final BDR. I think that's essential for us. Mm-hmm. There have been so many changes that I would, before this commission endorses, I think it's just good sense to continue to review whatever comments they may have. I don't feel comfortable doing it any other way.
Yeah, and just to that point, I just want to throw out that with the telehealth bill, I spent a good chunk of time reviewing AB 292, which was passed in 2015. Much of that bill actually covers a lot of the changes that we're looking at now. For instance, it talks about service parity. So then we have to look at what changes are we making? Maybe payment parity. But so all of this means nothing until we actually see the language. And I think even Chair Bond has talked about this, what are the actual changes that are being made to the law? So I'm looking forward to that. And I also like really hope that we can have a robust work session around that when that occurs.
So just to get back, because I know this is under the topic of my update to you all. If you have anyone who wants to collaborate with us, or if you have any information that you want to share to circulate to the commission, I would encourage you to reach out to me. I think that, you know, so that way we can plan accordingly. I can share, you know, thoughts with Chair Khan about his decision to call a meeting to order. And then Dr. Slonim, your comment about the substance abuse, that wasn't anything that was indicative of a priority topic. It was just a speaking to their board chair, wanting to make sure that we were aware. So this is just me delivering back the message that this is a priority for them. So they wanted to make sure that this commission was aware. So I committed to putting that in my update publicly. So that way, not only are you involved, but everybody's watching and all the public that's participating is also aware that they reached out and want to make sure that we do not have duplicative efforts and coordinate.
So this is Dr. Khan. If I may quickly, just to bring back us to focus, there are a lot of other subjects we are talking about, whether it's mental health, etc. I think if we focus on, as I had mentioned in my opening remarks, on the language for the 2 BDRs, and we need to look at the final draft that comes back and look at that again, and that's all fine. But for today, if we can focus what are changes, amendments, corrections we need in the current draft, then in the agenda after we have done that, we can look at other items that we need to either discuss, address now or in future meetings. That's my thought, because there are a lot of subjects everybody's already thrown around, which I was hoping will come after we have narrowed and finalized the language on the first 2. So we've made some progress, narrow it down, put it out, and then in this meeting, after those 2 are sorted out, then look at other options that we have been talking about and how to best address them going forward, if that makes sense to everybody.
Yeah, and if I could just respond to Sarah's comments about the language and how we put it out. If I could just urge, I guess I'm just all for transparency. So the greatest transparency, you know, like I was saying with my mental health crisis hold legislation, I have 150 people on my listserv, and I just like send stuff out. And if people want to be a part of it, I bring them in, because we either get the input now, and I think that's how you really develop like strong legislation, or if, you know, if people don't know about it and they don't feel comfortable about it, that's when you really get that fear, you know?
So if it is okay, I really would like to move on these other subjects, which are crucial, important. We have talked about them. Several commissioners have voiced their strong views and opinions, and I respect all of that. But at least let's start focusing on what we have on our plate to narrow down first as a priority. And then certainly after those 2 have been narrowed down in language, that we are supposed to fine tune further in order to meet our deadline on that subject. So let's do that first. And then in the item on the agenda, after we have done that, certainly discuss the other scenarios and narrow down amongst ourselves what should be our next step for the next meeting discussion and further input. Or if we decide today that there is a way technically, legally, etc., that has been talked about a lot on placeholders, etc., that can all be answered after we have finished the discussion of 2 BDRs, and then address all of those aspects after those 2. So I really would like to proceed with this and hold our thoughts for other items, subjects, unrelated to the main subjects of these 2 BDRs after these discussions have been sorted out. So I would like to do that. So I really want to make progress and wrap up some of the preliminary language for final approval that will come back to us. And then today move on after this to other items of consequence to each one of us, and collectively and individually. So having said that, so we are down to item number 7 for discussion of commission work plan and potential bill draft request. Item A, finalize bill draft request and language for submittal to Legislative Council Bureau related to telehealth and transparent policy. That's one. So Sarah, you want to comment on that? And I think we can start our discussion on that. You have a lot of information based on your and my discussions to get more input from the LCB on the technicalities and logistics, and also the AG. What are our options legally and or preferably? Please go ahead, Sarah.
Sure. Okay. I guess what I can do is I can start. I've shared my screen. I think everybody can see it. This is
Yes.
the language. And so what I did was add some additional items in here that I outlined to you all in my email from our last meeting. There was some comments about having kind of a base point for what are we trying to codify into law. So this bullet list is actually from Administrator Bierman's presentation to this commission, in which she outlined the emergency changes that they have implemented. So that's what this language is reflective of. The other thing that I committed to this commission to do was work with Commissioner Flood and Commissioner Bohannon on the equitable access piece for telehealth, and how do we accomplish that, right? I think we were talking about the telehealth and making sure that the goal was to address this, but it's not an easy conversation about how do we do that legislatively. So I worked with Commissioner Flood, Commissioner Bohannon, and I also talked to Director Whitley and his staff about some options around this provision. What we came up with was these bullet points. And I don't know if Commissioner Flood, if you would like to kind of take over and discuss with this commission your intent under this language. And then I can also elaborate on this data dashboard as well. But if I could defer to you on this portion.
Yeah, so I guess bullet 2 is probably what you're indicating to some extent, correct?
Right.
Starting with. Encourage current bandwidth providers to explore options and collaborate with community providers such as schools, hospitals, and healthcare, behavioral health providers to strengthen the bandwidth system. So what I've heard, especially in the rurals, but also in parts of Clark County, there's obviously issues with bandwidth, but there are providers out there that have current infrastructure that they could use to assist the hospitals and social or in schools. So there's existing opportunities that probably wouldn't take that much effort. And the problem is I don't know what that would look like in the law. I just wanted to kind of put that out there, that there are some probably low hanging fruit in terms of really making sure that we're utilizing all the current infrastructure that's out there. So that was to that. And I'm like, maybe you could work with LCB on that, or we could look at other states and how they've really tried to develop that collaboration. And I also added schools in there because this isn't just a healthcare problem. Schools also have bandwidth access. So really understanding all of the people that need that increased bandwidth and really trying to make sure that they're part of whatever solutions come forward.
Great. And so, oh, Chair Khan, hold on, you're on mute. You're on mute.
So I was saying if we can follow our procedure we have done before, is everybody can chime in regarding the language, their additions, subtractions, and concerns, and we'll have everybody's input first.
Okay.
And then go second round, get additional input so we can narrow down so that everyone has an opportunity to give their opinion at length that they would like to speak about, at least in 2 rounds, and hopefully narrow it down. So maybe we can proceed with that format, Sarah.
Sure, Mr. If you can.
Sorry.
Yeah, I just wanted to explain the other bullet like Sarah asked me to.
Yeah. The one more that just, this one? No, sorry, that's me. Where's the other one?
Well, I thought that was the Commission on Behavioral Health and Regional Boards, but if you want to talk about that, great.
Yeah, okay. So I guess the only other thing that I want to make sure that everybody's aware of, because that's different in this language, is the, like Commissioner Flood indicated, the opportunity to maybe increase broadband access to vulnerable populations being one component of this. And then a second piece is requiring DHHS to produce and maintain a data dashboard to and then also require, the second component of that is require the Commission on Behavioral Health and these regional health boards to include a review of the data dashboard in their duties. The thought process behind those 2 bullet points is really to accomplish something legislatively around equitable access, but not having a large fiscal component attached to it. We don't know what the fiscal ask would be on increased broadband access, but we do know that that does have a fiscal component to it that we would be likely having to address in the legislature. And so if you want me to talk about the council's recommendation that has been thrown out, this is one of the portions on this language. Although everything can be submitted under one bill draft, I worked with LCB legal to make sure that we were compliant with the single subject rule, and they feel that that is okay. This language so far, we could accomplish it, but there might be for you all to consider a policy decision to break apart this bill, particularly with this equitable access piece because of the fiscal component. So if you want to consider that as an option, that is something that I'd like to highlight. And again, even on this, we're still not sure exactly how we would accomplish it and what that would look like. And maybe that might be a longer discussion that you guys want to consider. So that's all I have to say.
So let's proceed, Sarah, with every commissioner having the opportunity to speak based on your preliminary talk about what the AG said about the possible split into a third BDR, etc. We all have that information. So keeping all that in mind, let's start with each commissioner so that we can go ahead and get everybody's input, which is crucial. So Sarah, could you please monitor that and start with one commissioner and move on?
Sure, let's start with Dr. Barron.
Yeah, I reviewed the language, and I think for the most part, I'm pretty comfortable with it. I agree with what was said before, which is that the addition of some of the things looking at equity in terms of access, I think is very important. I don't know how that affects or encumbers the goals of the original draft, but I think it is important, and I would be supportive of that, especially since most of the language that you added looks like it is probably more initiating discussions about broadband access and so forth. Another point is that about a month or two ago, I know that our federal our senators were looking at ways in which at a federal level they were trying to improve broadband access for rurals. That's not the same thing as urban centers in need, but it may be worth an ask for our legislative team in Washington to find out where they're at with all of that and see what the proposal was and the likelihood of its success in terms of how it impacts our ask about broadband. And otherwise, I think that those are my comments.
Great. Chair Khan, you're on mute.
Is that heard? Okay,
Yes.
So how about what I was suggesting, if we can kindly address our views on the language on the two bills in the first go around, any changes, modifications, amendment in the first and the second. We'll make note what you think needs to be amended, modified in Bill Draft 1 and Bill Draft 2. Then we can come around and Sarah, please take notes. I'm taking notes also. And then come back so that we have had a chance to address any changes, amendments in both bill drafts in our 2 rounds of discussion. So do you have any other comments on the other one, not the telehealth and broadband part?
Okay. Sorry, I wasn't prepared to talk about both of them.
No problem. That'll make it a little efficient, I hope.
Okay. Well, I guess Sarah, if you can sort of bring up on your screen the
Sure.
second one, then.
Let's see. Okay, let's see. Is this the, yep. All right. I've got the other one up for you.
So a couple of things under transparency measures, I guess, as you scroll down a little bit. I would agree with the first statement there. Oh, you passed it. Sorry.
This one on the okay.
Yeah, under that section, but the transparency measures specifically underneath that. I would agree with paragraph number 1, requiring an inventory. I would agree with that. Report each year summarizing healthcare quality in Nevada. So my concern about this is not that I don't think that the principle is a good idea, but I'm just confused as to how we are expecting a healthcare quality report, and from who. You know, the hospitals, for example, all have quality metrics that they have to report, and you know, in terms of patient outcomes and things like that. But beyond that, I'm not sure that there are standardized quality metrics across all physician groups, provider groups, etc. And so I'm a little uncomfortable with demanding a report on healthcare quality, because we really haven't addressed issues of healthcare quality at all and how we're going to measure that. So my personal preference is I think we need to either refashion that, or maybe we need to say that we need to work toward a report summarizing healthcare quality. But I don't think that we're in a position to really be able to collect that information right now. Quality, I learned in QI methodology that quality equals outcomes over cost, and it seems like we've been focusing a lot on cost, which is the denominator, but outcomes are a big black box to me. So I'm not sure that if the equation is quality equals outcomes over cost, that we know what our outcomes are all across the board. So just my comment about that, I don't think we're prepared to do healthcare quality. With regard to requiring a pre-transaction report to the state of Nevada, to this commission, I know there was some talk during the last commission meeting about the role of the AG's office and mergers and acquisitions and things like that. As a small, I mean, I can just only tell you from being a small private practice in Nevada, if I were to want to sell my practice or something like that, I might have a little heartburn over being required to report to the PPC whether I'm selling or merging or something like that. I'm not sure of the constitutionality of that in private transactions, and I guess I would maybe seek a little more advice about that. I would imagine that despite the desire to be transparent, I'm not sure why we're going after mergers and things like that. I know that they can affect the healthcare market. There's no question about that. But the bigger ones that have some issue with potential antitrust would be the ones I think we would be concerned about, and I think those are the ones that the AG's office would address. So I'm not so sure that I'm in favor of requiring a pre-transaction report of these mergers and acquisitions between private entities. And then the next bullet point, which is the report by facility the use of emergency relief funds. I don't know what the degree of reporting is of using emergency relief funds from let's say the federal government and state governments that the facilities have to use. I know that if we requested a PPP loan, for example, from our bank, that we have to submit to our bank, our lender, a ton of accounting detail and employee records and things like that. And so we feel like we're accountable to them for that. But other emergency relief funds, I can't speak to, and I'm not sure if there are other agencies that facilities have to report to. I think probably Bill Welch or the hospital CEOs that are on our commission could speak to that. And then the last, failure to submit required reports, penalties for that, and so forth. Again, I think it is dependent upon how much reporting we feel we can demand at this point in time. when I feel like we haven't even really been presented enough data to make those decisions. If you scroll down further in the document, the beyond the pharmacy claims section, I don't know, Sarah, if you can scroll down a little bit further. Sorry, I think a little further than that. The hospital price transparency, again, I would be interested to know what the current reporting requirements are, because I believe that there was some federal legislation that passed, and I can't remember if it was on executive order federally or not, but again, our hospital CEOs could speak to the existing requirements that the hospitals have to comply with, and whether this adds just another layer of administration, or whether they're prepared to report to yet another venue or not. So again, I'm not sure about that. It's just an area of weakness of mine. I don't know what's currently being required, and I guess I would just like to hear a little bit more about that. Scrolling further beyond the hospital price transparency, I'm in favor of the all payer claims database, as we've talked about. And I'm not sure that I am, as a member of the Patient Protection Commission, I'm not sure whether we are being a little premature in asking for more authority with, for example, with the ad hoc reports and things like that. I feel like we're maybe not in the know before we're asking about that, and maybe one or two of us are, but I just feel uncomfortable asking for more authority when I'm not sure that we've gone through kind of our first cycle of this, and we know, what our role really could potentially be. So again, maybe I just would proceed with trepidation on asking for more authority at this point. Those are my comments, I think, on the second BDR.
Thank you, Howard. Who's the next commissioner in line for us?
Sure. And Mr. Chair, if I can for a moment, I actually didn't realize that we were going to be talking about transparency at this point too. So I would be remiss if I didn't mention the comments about the topics to be considered for potentially breaking apart this BDR that council had raised to me. And given Dr. Barron's comments, I think it's exactly aligned with what was stated to me as for consideration for this commission when you're looking at this transparency. So although we did get clearance, preliminary clearance that we could accomplish all of these provisions under one bill draft and under the single subject rule. However, the items such as, and I think I wrote it this, but what Dr. Barron mentioned, we'll go back to this report by facility. This was one that was actually just, it seemed quite narrow in regards to everything else that was kind of captured a little bit more broadly, and your intent is to require reporting. This one being so very specific was kind of highlighted. Maybe you want to have a separate discussion, and maybe that does make sense policy wise to have a deliberation outside of this measure. But I think the one that was highlighted the most was the review process. And the review process, like you have two sets, you guys are all trying to require reporting and of data, but then what does that review process look like? And that is back to the role of the commission. And so really does it make sense to have a policy discussion and for this transparency being about what data you would like to report, and then maybe a secondary separate piece about the review process of these reports. And so those are some of the things that were mentioned to me, and I wanted to pass along to the commission.
Okay, thanks, Sarah. So let's move on to the other commissioners. And I like the thought that like Dr. Barron went over each item about his concerns or agreements. If we can follow that format, that will be very helpful to keep focus on every item and get a consensus or lack thereof on the
Chair Khan,
items. So,
Chair Khan, just one comment. I don't know if other commissioners, maybe this is my own limitation. I'm having difficulty bouncing back and forth between the two BDRs. Maybe we could do, I'd like to suggest that maybe we could handle one in detail and then go to the other one, because the back and forth has got me a little Zulus.
I agree.
yeah, so that's fine.
I agree.
Makes sense. So let's do that. So let's focus on the first BDR and come around for the second. That's perfectly understandable. So Howard has already given his opinion on both. So let's for the next, let's do that. Thank you.
Okay, great. Let's go back to, I think we're going to go back to the transparency. So that helps. Let me pull that one back up. Hold on. Let me share my screen.
We're going to I'm sorry.
I mean, sorry, telehealth. No, we're gonna go back to telehealth. Sorry, we'll start with telehealth, and then. So we've heard from Dr. Barron. I'm going down my list. Dr. Packham.
I don't really have anything to add other than that second bullet there, and maybe Jessica could help me scroll down. Actually, the encourage current bandwidth is the idea there just to expand the range of potential sites where a consultation could take place. It's not asking for more dollars or.
Right. So from what I've heard, other states have been able to show that there's a lot of benefit for like huge companies such as Sprint, AT&T. They're all out there in the rurals, and they're also in Clark County, to be able to expand, broadband access to communities. So to patients who may not have that, even if it's a small number population. So I think it is like more of a pro bono act. So I don't know what that would look. I certainly am not asking for any type of fiscal note on this, but the intent is just like, hey, you're there, you have a lot of money. Is there any way that you could do the right thing and help some of these people out? I know.
I think that could be a twofer if it ends up enhancing healthcare in schools-based settings. So that's all. I don't have anything to add on the telehealth.
Okay. Do we want to go down to, say, Dr. Slonim?
Sure, thank you. Just a couple of things, not anything particularly major. If you scroll down, Sarah, if you wouldn't mind, to the part where it says private payer parity.
Yep.
There you go. I just some details here. I'm not sure why we suggested private payer and not all payer. That struck me as odd.
Sure.
So that's one thing. And then under paragraph 2, payment parity, we say the combined amount. I would just strike combined, the amount of reimbursement. And then down 2 sentences below that, not be less than the amounts. I would get rid of total. Yeah, right.
Right here, then the amount.
Get rid of total there. And make it amounts, plural.
Okay.
And those were the only ones I think that I had. Thank you.
Okay. Mason?
Okay, this is Mason. Sarah, I did have, I think on the third bullet under equity access, I just wanted to understand the required DHHS to produce and maintain a report. I know we have Mr. Whitley on the phone here, and just was curious on, does he currently have the staffing to do that? I'm not a big unfunded mandate kind of guy, so I just wanted to see what that would look like from a time requirement. And then the other one under that as well, that section is when we say require commission on behavioral health and regional behavioral health to review the data dashboard. Is that something that we want to go down. It could be a slippery slope of one commission requiring another commission to do something. So I just wanted to know the thought process around that, and I agree with everybody else's assessment on this particular bill. I think there's going to be more discussion on the next one, but those were my two. But I just, based off our economic conditions and where we're going to go and potentially 4 or 5 years to recover, I know the department's going to be in a very tough budgetary constraints. So just want to make sure that Mr. Whitley can deliver on this and he's not put in a position that makes it more difficult to do his job.
Great. Yeah. If I can take a moment, Dr. Whitley, if you want to chime in, I would appreciate it. But what I can tell you is that this is a kind of conceptual language at this point, just to try to capture this equitable access piece. And so it's really just a initial thought right now to collect information around vulnerable population, and especially with telehealth services, and then having a placeholder on either our website or their website, and to make sure that this doesn't get lost in the decision-making process within the state. And so the requirement for the Commission on Behavioral Health and regional behavioral health boards, I don't see anyone not agreeing to that. I know I've had some discussion with both the Washoe and Clark, and I think Jessica also could speak on this too, that it's not really a harsh requirement. It's really just saying, hey, we're going to collect this information. We're going to collect the data. It's going to be housed publicly. We want to make sure that your board also reviews this data and puts it in a part of your duties. And so this was kind of a creative way to try to capture the equitable access piece. But if Director Whitley, if you're on the line, and so I did not suggest this without having conversation with DHHS to make sure that they could do this and they can do it within their work now and have information to produce something like this.
Thanks, Sarah. I'm good with that explanation. So thanks for doing the diligence behind it.
Great. Okay, Bobette.
Thank you, Sarah. Thank you, commissioners. I would like to go back to the language that Dr. Slonim, Commissioner Slonim just changed, because I'm not sure. I'm not sure. And Commissioner Shaner.
Highlight it.
Yeah, Commissioner Shaner helped with this language too. So I hope you're looking at it, Commissioner Shaner. But it sounds like now a health benefit plan, we'd have to reimburse the total amount allowed for healthcare services provided in person, instead of just, it seems like now it's expanded what would be paid beyond what was intended here. We're paying parity. We're trying to pay parity. Allows for the compensation, but you've taken out, you've left total in there. I think maybe leaving total in there is the problem. Do you agree, Commissioner Slonim?
Yes, I had suggested taking total out. We need total out. Yeah.
I think total outlines the thing back up. Okay, that was, thank you. I appreciate the housekeeping issue there.
Yeah, no, thank you for pointing that out.
I think the second issue is, if we could go to Commissioner Flood's bullet point about encourage current bandwidth. I know there's been work done on this in the state. When the telehealth law passed, there was quite a bit of work done to try to figure out how to expand broadband. And I know that AT&T was involved in helping do that. I know there was money in the state that the hospitals helped do that. So it almost seems like this fits to me into, should we include a bullet point here about assessing the current status so that we know what's left, we know what didn't work, we know where the holes are, because we know there's holes. But this kind of goes to my whole conversation about my whole transparency push. If we don't know what we've got, how do we ever make change? So we need to know what we've got. So maybe this could be tweaked a little bit to say, assess current access, so that we've got at least an action there, and that could be in statute. And then that would give us some room to develop, what's left and how do we encourage that. With Commissioner Flood, do you think that would be a helpful clarification?
Yeah, I think that that's a great idea. I like that addition.
Okay, so let's do this.
And I guess I always think about the deliverable and even having a report. I think that is where like the DHHS, the data dashboard can also show broadband access throughout the state.
Right, and we will be able to with it, and I left it broadly enough to require the data dashboard because the components of that will be determined. This is just kind of the conceptual language at this point.
I think that would be my main thing, just so we can get that in because that could be a LCB actionable item, and I see we're struggling a little bit with how to put the rest into law. So that's my main thing. I think the rest of the law looks, rest of the BDR, I'm good.
Okay.
All right, who's next?
Mr. Shaner?
You're muted.
Thanks, Bob. I appreciate it. Couple comments. If you scroll up to the top, Sarah. Keep going. First bullet, it just seems to be some inconsistencies with respect to telephonic. So if you look at the first bullet here, it talks about how audio would be allowed. If you scroll down to the bottom of this section where there's a reference to home health and hospice, it tells
Okay.
telephone only is not allowed. And then physiosocial talks about how audio and visual must be used. And then later on, we say telephone, exclude phone call service from payment parity. So I know we've spoken ad nauseum on this with respect to reimbursement for telephone only not being eligible for payment parity with respect to going forward. So I just want to make sure that we're consistent throughout the BDR with respect to how we would treat telephone. And again, I don't want to decrease access, but and I know we clarified here, I just want to point that out. Under expansion of services, again, this just goes with the inconsistency, I think, which is at the bottom of the first page.
Yep.
Again, here it talks about how all telehealth services an expansion during COVID state of emergency should be allowed to continue going forward. It might be worthwhile to put in there after forward a parentheses with unless otherwise noted and shall be limited to covered services.
Can you repeat that? Where am I going?
Should be continued right after continue. And then it would just be parentheses unless otherwise noted. And shall be limited to covered services. And again, I just want to make sure it's consistent with respect to how, I don't want there to be a misinterpretation with respect to telephonic. And then to Dr. Sloanum's or Commissioner Sloanum's ad, I don't know if there would be a fiscal note if we include state agencies, perhaps. I don't know how Medicaid, off the top of my head, reimburses for telehealth, and they would then be included on this with respect to all, which I agree with Dr. Sloanum, but just pointing that out for the purposes of the commissioners on here.
Okay, thanks, Sean, Commissioner Sean. So I appreciate you bringing to light some of the sort of disparities between the language, and certainly it's worth looking at. So let's move on. Who's the next commissioner online?
Flo? Ms. Khan? Oh, sorry, you're
Can you hear me?
Yes, now we can hear you.
There you go. Okay, sorry. In looking at this, I really don't have any additional changes that I would view. I think this looks fine from my point of view. So I'm good.
Okay.
Thank you.
Jessica?
Who's next? Who's next in line?
Jessica, do you have any thoughts?
Yeah, so I just wanted to talk about if you could go back up and can we scroll down? I thought that there've been really good comments so far, just in terms of the reports from the behavioral health policy boards and commission, just to clarify on those.
Yep.
So I think it's just like a grant deliverable that if you have something that you must do by the end of the year with a report, it makes people discuss the conversation. And I really like the idea of the data dashboard because, for instance, the state just started doing a minority health report. And to Commissioner Bond's point, if you don't have any data, if you don't know what you're looking at, then the conversation never starts. So I think that at least from me being on the Northern board, I think that that would not be a hard thing to move forward on. In terms of the telephone piece, so I'm not sure what Commissioner Shaner was, if you're pro or con. I really like the idea of making sure that we're not conflicting ourselves here. I just think, why I push for the telephone is out in the rural counties, and I think, and even in other areas where there's impoverished communities, they don't have a computer, they don't have a smartphone. So just really making sure that we allow for those services when appropriate to be provided through the telephone. And from what I've heard, so like you said, Commissioner or Chair Khan, telephone is not covered under telehealth, it's telemedicine. And I don't know if that may be totally bold to include telehealth under telemedicine, but just from what I've heard, the more flexible we can be on this, the more people that we can provide services to.
So that's a good comment there. So my personal view, and I had voiced that last time also on this subject, is telehealth is telehealth. I mean, if there is a telehealth visit expected, required, and done, and the important thing is required, that the provider needs to have a telehealth access to make some determination appropriately. That should be made available, and that's what this bill was all about. However, the telephone part is not a part of this. There's no parity between whatever the telephone access is currently available and done and is appropriate is still done. And we are not talking about reimbursement or payment for telephone discussion with the patient or between the provider and the patient, etc. It's a separate issue. And then, as my recollection is of a last meeting, is this only applies to telehealth visit where appropriate and needed. So to your point, yes, the rural areas, some, telehealth, they may require phone conversation, and that may be necessary or minimal requirement, and that stays as it is. That should not change. And in some cases, to be fair, in this urban areas, in some places where still the same issue may exist and a telephone conversation is required, then that should be a telephone conversation. And that is not a part of parity vis-a-vis telehealth access.
Okay, could you just scroll? I appreciate your comments, Chair Khan. Could you scroll back up to Suzanne Bierman's recommendations? I guess, yeah, I think Commissioner Shaner just had some good points, and I'm not sure, Commissioner Shaner, do you think that it's aligned now, or were you pointing out the inconsistencies, or what would you recommend?
Yeah, I don't, so this is Commissioner Shaner for the record. I still see conflicting information in these bullets. Again, the first bullet says can be provided with audio only, and then home health talks about telephone only is not allowed, and then the last bullet says audio and visual communication, which to me is not telephone only. So and then again, that other bullet on the second page talks about how telephone only is not eligible for payment parity. So I just want us to be consistent is all. And I think the way to be consistent would be that telephone only is eligible to be conducted, but is not eligible for payment parity, which is what I tried to get at with the unless otherwise noted bullet. I think you can caveat some of these things is, and I'd probably have to study it a little bit longer with respect to get exact language, but I think we've made our point with respect to how telephone is eligible to be conducted, but not eligible for payment parity.
Great, I support that. Thanks for clarifying.
So Sarah, have you captured the thought process of Commissioner Schoner and
Yes.
Jessica Flood?
Yeah, I believe so. And I really think that this is what the intent is. And when they're going through the drafting process, if legal has a question, they'll reach out to me and I can always go back to this discussion. And I've taken notes to make sure that we capture it accurately. So I believe we're okay. If somebody feels strongly one way or the other and you would like to omit these bullet points, just so there isn't a confusion, by all means, we could certainly do that too.
So we'll go ahead with the other commissioners and they can opine. And in the second round, those who have not opined yet, they can certainly chime in additionally if they agree with the language being proposed or need some changes. So moving right along, our next commissioner.
Yarleni?
Hi, yes. So I agree with everything that's been done so far. I have a question though. I don't remember if in the last meeting, did we take into account what the Dentist Association was talking about? Or is that part of the expansion of service? Because I know that in the legislative intent of proposed bill, there are some things that are specifically said on it. I don't know if we need to add the dentist or would that be included?
So I can speak on that briefly, if that's okay, Mr. Chair.
Yes, please.
Okay, so I think the agreement was really to make sure that it was limited to covered services by providers of healthcare, and then as defined by NRS statutes. And so I put the provision in here so that way it makes it really clear, and dentists are captured under that definition. So provider of healthcare is defined by this statute, NRS 629.031, and then under that captures dentists. Now, so I think that covers it, but I would defer to the group if there is a specific reason to exclude it or thoughts otherwise.
All right, good enough, well noted. Our next commissioner.
I have another comment,
Sorry, go ahead, please.
Yarleni. And then I have a question about, is there a reason why we're waiving the requirement for a nurse to conduct an on-site visit every 2 weeks on the home health part?
Where it is. You have to direct me. And, I think we have Administrator Bierman on the line. These are the bullet points that she provided to us as kind of what is happening with the state of emergency. So I don't know the specificity of that detail. So we could, if Director Bierman is on the line, if she wants to speak on that bullet point.
So is it online? Do we have them?
Oh, there she is. I don't see, hold on. We can't hear you. I can see you.
Yeah, I don't know. Can you hear me now?
Yes, yes.
Okay, sorry about that. So yes, these are the changes that within the Division of Healthcare Financing and Policy we have implemented during the course of the public health emergency to ensure access to care at a time, when individuals are socially distancing. So could you repeat the specific question?
My question was, is there a specific reason other than the COVID right now and given the emergency to waive the requirement for a nurse to conduct an on-site visit every 2 weeks?
Right. So right now, all of these were put into place back in March, and really the primary driver behind all of this was ensuring that services were able to be continued during the course of the public health emergency. And some of these flexibilities, we are able to have the authority from the federal government under what's called an 1135 waiver. And some of these will expire at the end of the public health emergency unless additional action is taken by the federal government to preserve this beyond the public health emergency. And we do know that the current administration is certainly interested in continuing a number of the flexibilities that they've granted during the public health emergency, but specific to Medicaid, we're kind of in a holding pattern and wait and see what happens post public health emergency, because right now we're able to provide this additional flexibility under that authority that is time limited to the public health emergency. So I'm not sure if that is a very long-winded way of answering your question, but definitely the reason that this was put into place and we changed policy was just to ensure that we weren't requiring unnecessary face-to-face contact during a time that we wanted to promote social distancing, but also still wanted to make sure that those critical services were able to be provided.
Okay, my confusion was just, I thought, so we're waiving the need to have a face-to-face meeting, but the nurse still has to do the visit using telehealth every 2 weeks in order to continue the service, correct?
That's my understanding, and I can follow up with our specific staff, but it's just the modality is my understanding that's changed during the public health emergency, but I'll follow up and make sure that my understanding on that point is correct for you.
Thank you.
Thank you.
All right. Moving along, who's our next commissioner in line?
That concludes the first round of commissioners. If you want to circle back, or if anybody wants to raise their hand.
Yes, please. We'll circle back, and I would really appreciate, we need participation of every commissioner, even if they just say agree or a period, but that's very helpful to have everybody's input in the second go around based on comments made. So we really would then narrow down the language as Sarah's keeping track of various inputs and address that.
Want to go back to Dr. Barron?
So just to be clear, are we talking about the telehealth bill again?
Yes.
Okay. No, I mean, I think I would agree with the comments that have been made and the slight wordsmithing changes that you put in. I'm maybe a little questioning about the unless otherwise noted comment, because I think I understand the intent that Commissioner Shaner mentioned. But unless otherwise noted could imply a lot of things, such as unless otherwise noted contractually, or unless otherwise noted somewhere else in this PDR, or unless otherwise noted in NRS or what. So I'm not sure if we need to be a little more specific about the unless otherwise noted comment. Those are my only roundabout comments.
Thank you. Next commissioner, please.
Dr. Packham?
I have nothing to add.
Dr.
Thank you.
Slonim?
Next.
Thank you. I just have one question. I'm just looking at this again. Sarah, would you mind please scrolling to the payment parity section again? It seems to me as I reread this that it's setting a floor, including both the originating site fee and payment to the distant site together. Essentially, that will be a pay cut for those that are delivering the care that have invested in telehealth equipment and services, it seems. The amount of reimbursement a health benefit plan includes. I think that there should be something in there that's a little bit distant site and originating site. That's where I'm hung up right now. Sounds as though we're reducing the total reimbursement with that message, with that language. Is anybody else seeing it that way, or is it I not? No?
This is Commissioner Barron. I would say that if to make it maybe clearer, if you added at the end of that sentence where it says allowed for healthcare services provider in person, to each the distant and originating site. So to keep the two issues of reimbursement completely separate.
Yeah.
So Tony, to your question, I don't think that the intent is to imply that the combination of the two is equal to one in-person visit for the total, and that's why we got rid of the word total. I think that was your point in the first go round. But just to make it a little bit clearer, these are two separate reimbursement points, and I think that adding that at the end would make that clear.
That's very helpful, Commissioner Barron. Thank you. And I'm in agreement, Commissioner Khan. Chair Khan.
Thank you. Please go ahead with the next person online, commissioner online.
Mason?
No additional changes. I do appreciate the clarification from Commissioner Dugan on dental, because I think that should be included. And Mr. Chair, just one question. I know we talked about telehealth and telemedicine. Where do we finalize on that? Are we going to use those words together in this build BDR, or are we going with one or the other? I just want to, for clarification, knowing when we finalize this, that everybody's under the same assumption that both from a video standpoint and telephonic, we're talking the same thing. Just for my education.
Right, so that's a good question. So I think once we have completed everybody's input and the language, as Sarah's keeping track of various input, we'll narrow it down, and I would like to have a consensus, or at least if not a vote, that everybody's in agreement with that final language that we all agree upon after all this deliberation. Does that answer your question?
Yes, sir, it does.
All right, great.
They're probably both defined in statute, aren't they?
Sorry, what was that?
John Packham, I was just guessing without looking that both of those terms are probably defined in NRS.
Yeah, or CMS too, Commissioner Packham. That's a good point.
All right, so moving right along with the next commissioner.
Babette?
Sorry, I don't have any more comments on what we've already done here.
Thank you. Who's the next commissioner in line?
Mr. Shaner?
Just a quick question for Commissioner Slonim with respect to distant and originating site additional language. Is the intent there for there to be additional reimbursement that might be above and beyond what the provider would have received for an in-person visit in order to compensate for technology or transmission costs? Is that what you're asking for?
No, I guess the point is, as long as the object is parity, and I wasn't sure based on the language, that it's not looking for something that's above, it's about distant site should be the same as in person. We want to make sure that the language, I think, was mostly what had me worried.
Okay, perfect. Then no additional comments or questions.
Right, good. So that's a good comment from both. And basically, right, both commissioners are right in that understanding. There's no additional cost. It's just that parity across the board for telemedicine. So our next commissioner.
Flo?
She on mute?
I'm good. I'm
okay.
good. Yes, thank you. I'm good with all the changes that have been made.
Thank you. Any other comments?
I've got Jessica Flood.
Yeah, so I don't mean to be a dog with a bone on this, but I'm just wondering, so we took it as just this given that we're going to exclude phone call service from payment parity. Is there evidence that we're basing this on? I just worry sometimes that this commission just makes like gut decisions that isn't based on research.
So to your question, I think all along in our discussion in the previous meetings, we have focused on telehealth, and we have very consciously, most of us, if not all, have said that, telephonic is separate from the telehealth component of it in terms of parity. And the feds have not addressed that either to talk about parity, and there's no discussion locally. So my understanding in our discussion in the past, the parity applies to telehealth, which has been a big issue. The telephonic component, telehealth has become more significant and prominent now. The telephonic conversations have been in existence forever, as much as they may not be utilized as much, but the question becomes very complicated. If you say telephonic conversation has parity, does that mean if a patient is calling and trying to reach a doctor for a couple of questions about medicine, and another patient is reaching the physician or provider rather, for another simple question, we may end up in a Pandora's box of trying to determine the parity. Is the parity for a prescription call clarification? Is the parity on I'm sneezing today, so I need to this, so we create a parity for a sneeze call. So it becomes pretty kind of complicated in trying to create a parity. When we talk about telehealth, obviously, we are talking about an appointment, a discussion on a specific issue, whether it's a follow-up appointment on a particular ongoing underlying problem, or it's an issue of consequence to the family, or to the patient rather, that is being discussed. So that's why I believe that telephonic part has not been a parity discussion, both at the national level and or at the various state levels.
So, and to that point, I think you're right that it's super complex and it'd be really hard to figure out how to regulate that. I just wonder, it seems like putting that exclusion in law could really be limiting for, future development. So I'm just wondering if we could even leave it as like status quo wherever it's at now, as opposed to like explicitly excluding telephone, because I get that from what you just said. From the doctor's point of view, that makes a lot of sense. We don't want fraud. From the mental health point of view, the therapy point of view, there's not much difference in sitting in front of someone and talking to them versus having that. A lot of therapy is delivered via phone. So I think there is a lot of nuance, and I just want to make sure that we're not just kind of throwing something in there that could have unintentional consequences, unintended consequences.
Okay, so that's my personal view. Is I honestly don't believe it is necessarily, because the telephone discussions have been on forever. Telehealth is relatively new, and there's never been a concern by anybody raised about the telephonic access, etc. So that's my personal view. That I think my view is to leave it as it is, and if somewhere down the road there is some unintended consequence, just in case. That would be noticed not just by Nevada, it would be noticed all over, and feds and all, and they've looked at that. Certainly the feds have from a CMS perspective, and they've not felt that that is of any concern or consequence to them at this point in time. So my personal view would be to leave it as it is rather than get into a whole different phenomenon. So I'll leave it at that, and let's hear from other commissioners what they think. So our next commissioner in line.
Yarleni.
Yes, so I want to make a comment about what Commissioner Flood just talked about. So I had not thought about it in the way you just mentioned. I was in the same kind of thought that we want to accept telephone calls for parity of pay, because it would be unfair for the patients to have to pay for a visit that it was just a telephone call, maybe a 10-minute telephone call, the same as if a doctor was actually assessing them, right? Even if it was just by video. But you raised a good topic there with mental health. It would be the same way, a telephone call or in person, it would be the same. I think maybe we could add a point where it says that specifically for mental health or therapy visits, it should be parity of payment, because there is not a physical assessment needed. I don't know what
All
the
right.
other commissioners think.
I obviously love that idea. I think that's a
You-
great idea.
So I think we'll continue our sequence of commissioners. So when we get the final draft language going to get everybody's input, we can see what everybody believes and thinks in that context. So who's our next commissioner, Sarah?
That concludes the round, but I do have one commissioner who raised their hand. So,
Okay.
Bobette.
Thank you. I'd just like the commissioner to say again, I'm not sure what the proposal was that she just mentioned, and I was trying to make sure I understand it.
I think, Sarah, you took note of it?
Yeah, so I think that the way I captured it was whether or not this commission wants to include in the payment parity for telephonic modality to be in the same as in-person for mental health services or therapy services. I think that is what is being talked about. Did I capture that correctly, Yarleni, Jessica?
Yes, that's correct.
Well, then could I ask Commissioner Flood, does that not already happen if the payment parity for mental health works out? Does that not already get captured under payment parity for mental health, the separate like payment parity pillar?
This is purely for the phone. So they were going to exclude phone, which makes sense maybe for medical visits. I don't know enough about that realm. But I have to say, I think billing codes actually really captures like what the people are doing. I know to Chair Khan's concern, like what's a sneeze call versus something else, but I think billing reimbursement filters that. But this is specifically for like a phone call for therapy. Like that could really help a lot of people out there who don't have a computer or a smartphone. And it's the same quality if you think about it. We don't need to like check the medical, there doesn't need to be any medical in-person checks that occur that would decrease the quality.
Well, I'm sorry let me go back to our protocol where I'm not talking directly to the other commissioners, I guess, but it's helpful to talk to the other commissioners. I think that we are really concerned about this bill in general. Can I just say that we're concerned that we're creating mandates for payment? And I know we're talking about we're not mandating rates, but we're just mandating equity. And so we're trying to push ourselves along in our health plans that I'm involved in to get there, to make sure that we can support the goal, because the goal is increasing access to service. But I think if we don't have some caveat in there about payment on the phone, then the situation of Dr. Khan's sneeze call or even just our outreach people just calling to make sure somebody got their medicine and things are okay, start to become eligible for billing. And I think that will cause us cost issues, frankly, in our nonprofit fund that I don't know how to support, but I want to support access. So I would be concerned about taking this section out completely.
Right. So Yarleni, I think, was saying that not to take the section out, keep that section in, but just allow for payment parity for telephone, for behavioral health counseling. I mean, I think that it would be a pretty narrow exception, but worthwhile since we're 51st in the nation for mental health.
So if I may just put my 2 cents worth based
Is this
on
what you're looking at?
Yeah, between the two of you, the discussion, even in mental health, in my experience, talking to mental health people and others, a lot of calls of mental health are related to prescriptions. Well, I've taken this prescription you prescribed me last time, it's not working, and they have a 2-minute conversation with the psychiatrist or mental health specialist or psychologist, nurse practitioner, etc. And they get an answer, oh, okay, yes, this is this. So how do we, once we get into that area, we're getting it into, well, how do we, well, mental health call worth 10 minutes, well, or a mental health call specifically on discussion and therapy. So it becomes a kind of complicated issue for us to tackle. And I really would be concerned, as I said earlier, it opens up a Pandora's box. There's already some, I know the providers can speak to it. they have some understanding if it's a telephone call of consequence, there is some interest in that for the physician or a provider rather, to explain that to the insurance carrier or provider of insurance, to explain why he or she wants that extra payment for a phone call. And I'm sure they have a process to address that, and Babette or Sean Schooner can talk about it, and I would like to hear from them. But I personally just think it opens up a Pandora's box, even in that narrow component. Then who's going to break it down 1, 2, 3, 4 to this much call, or drug call, or just a discussion? I didn't sleep last night based on your medication you gave.
So you're speaking of psychiatry, and I don't know if I'm asking for psychiatry because I think that does go back into that doctor realm. But I think just a therapist, you know, it's pretty black and white on like what that looks like and how much time you spend on the phone with that person. And I believe that it's billed usually in 15-minute increments. I mean,
Mr.
I know
Chair?
we're dicing it too much.
Sorry, go ahead. So,
Mr. Chair, this is Mason. I think maybe we're getting and this is good conversation, but I think we could perhaps fix this up in the definition parts of, you know, telehealth, telemedicine, and then as an organization that, you know, seeks out reimbursement on 500,000 Nevadans every year, we can't forget that there's coding processes involved in both those venues. So obviously there's always a support of documentation and a note or a record to be able to support whether it's level 1 or level 5 visit. So I think we may be getting a little too far in the weeds on wondering the what ifs, but I think if we define it up at the top of the bill that, you know, we don't seek to change any coding or, you know, HCPCS codes or surgical codes or any of those type of things, that it would still always remain defined by CMS in the Department of Health and Human Services for the state. So maybe that's our fallback to make sure that there's equity in both reimbursement but also payment for patients and deductibles. Just my thoughts.
no, that's a very good suggestion. So I think we need to move along on this to get narrowed down on the subject so we can wrap this bill draft. We are getting tight on our time. So is there any other comment that we were missing, Sarah?
No, I don't have anybody else who've raised their hand.
I just wanted to say I appreciate Commissioner Van Houweling's comments and I support that.
All right, great. So Sarah, could you please narrow down the language that has been sort of generally of consensus during our very valuable discussion, I would say, and without being too prolonged, which is a great thing for all. So if you could narrow that down and everybody can look at it, and then we can take a vote or just a hands up, whatever it takes.
Okay, so just based on the discussion that you guys just had on the telephonic modality and the payment parity for other services, I left the language the same. So I didn't make any changes to that. It sounds like we're capturing the intent, and we can certainly work on the details when we get it back from LCB. And then of course, this is going to have a legislative process. So this is really just the first step. So I didn't capture that, but the other changes that were captured during this discussion was under expansion of services, to add under that, unless all telehealth service type expansion and reimbursement models during COVID-19 state of emergency should be continued, with the added caveat, unless otherwise noted, and shall be limited to covered services. So that was captured really just to make sure that the intent was outlined. And then switching private payer over to all payer. Now the thought process was with the private, as Mr. Shaner pointed out, was to make sure that this isn't a mandate on the state, which would then trigger a potential fiscal note. So do you guys want to leave it as all payer parity, or put that back to private payer parity? The other language that was changed is switching the payment parity portion to indicate not less than the amounts allowed for healthcare services provided in person, and then adding to each the distant site and the originating site, again, to make sure we're capturing the intent accurately. And then under equitable access, this is all new language. And then on the second bullet point to Commissioner Bond's request that we need to assess current access and to add that to the conversation is we need to make sure we capture what is already what's already out there. So that concludes my additions. I don't think I missed anything, but the other part that you might want to talk about is the state definitions of telehealth. And so that's something that was kind of mentioned broadly. I don't know if we want to embed it in this language or if that's for a deeper discussion through the legislative process.
So when you're saying state definition of telehealth, it's already incorporated somewhere.
Yeah, I'm just saying, I think that did you want to change it here? I think Mason mentioned the definitions. And so I wrote a note on here if we wanted to add any language around those definitions at this point. I don't think so, but that was another topic under this BDR that was mentioned, so.
Yes, Sarah, this is Mason. I think you could just point to, reference the state's definitions and not define it because it could evolve over time, but always seeking out that it should be followed to protect the patient and access.
Great. So there's no changes. So then we don't need to add that to this language and then that's just really for the intent. We need to follow the state definition. So I just wanted to make sure that we were all on the same page with that.
So I think we need to wrap up our discussion and extensive input for everybody and narrow this down to take the final consensus vote or otherwise from everybody, unless one is extremely, extremely compelled to say something additional.
Okay, it looks like we've got Dr. Barron who's raised his hand. He'd like to speak.
Okay.
Yeah, thanks, Sarah. Thanks, Chair. So with regard to the question that Sarah just brought up about all payer parity versus private payer parity, the intent of the federal emergency legislation was all payer parity. It was not singling out private, etc. And currently the state of Nevada is receiving extra funding in order to be able to fund that need for Medicaid. And as a provider who sees predominantly Medicaid patients in my practice, it definitely helps access to be able to include all forms of Medicaid, whether it be fee-for-service Medicaid that the state administers, which is a small percentage of the total, or one of the MCOs. I think it's important to keep the term all payer parity rather than just private.
Okay.
All right. So current language, I thought it said all payer parity.
Yes.
It already says that as we all talked about it.
Yes, I was just highlighting that was a change.
Oh, okay. All right. So I think we are ready to take a vote, perhaps.
Mr. Chair,
Yes.
Mr. Chair, I'd like to make a motion to make a motion to take a vote on the proposed changes that we discussed this morning that Sarah's captured in the document. So I'd like to make the motion to take it to a vote.
Okay, do we have a second?
I'll second.
Okay, so all those in favor, either everybody can raise your hands or I can run for a vote. If anybody is opposed, please raise their hand. Sarah, do you see anybody?
No, I don't. No one has raised their hand.
Okay, perfect. So the motion carries by just about unanimous consent, which is excellent. So at least one bill out of the way. Great job for all the commissioners. Now the vote.
Excuse me, Chair, can I ask a question?
Yes.
Who seconded the vote? They didn't identify themselves.
I think that's Commissioner Flood.
Oh, thank you. That's all I needed.
All right. Thank you. Thank you, everybody, for this one BDR discussion, finalization of draft. So moving on to our next bill draft on transparency, right? So let's start the same process, if we may, and get everybody's input on the language as currently submitted to everybody. But before we go that, Sarah, do you have anything to advise the commissioners based on your discussion with the LCB and the AG's office?
Sure. So I'll kind of be brief, but what I had mentioned earlier in the meeting was the discussion about making a policy decision to break apart some of the components of this transparency bill draft. It is quite large and it's quite ambitious, I think. And so some of the points that Dr. Barron mentioned earlier on was exactly what was highlighted from various council as to consider breaking apart, such as requiring a discussion or a separate BDR for the role of the PPC in the review process on those reports. And then there was also, I think, a recommendation for looking at the inventory of health data, meaning that seems like kind of a larger ask too, just to kind of capture what is out there. How do we inventory that? Another one was the provision about the emergency relief fund facility reporting. That one seemed a little bit narrow, and also not sure if you want to have a separate conversation and then pull that one out of this bill and just have that utilized as a third BDR to consider. So
okay, thank you for that input as the basis for our discussion moving forward. So I think we'll move ahead with our discussion and open it for each commissioner to please comment, and would be helpful if you can kindly comment on each item, your views, so we can capture each item on the current draft bill, what your opinions are. So let's proceed with whoever is up front in the raise. And sorry, before I go there, I just want to remind everybody it's 10:50 in the morning on Monday, and we started at 9 a.m. I suspect there'll be some robust discussion on this particular draft. So I can take a break at 11 for 5 minutes, but ideally, if we can wrap it up by 12:30, that would be huge. I just hope so, but I can certainly take a break at 11. What's the desire of the commissioners? Should we take a break at 11 for 5 minutes? I would like to suggest that because I suspect it'll go to 12:30. Anybody says no? For everybody at 11, we'll take a 5-minute break if that's okay.
I would like
should we ask everybody to raise their hand? If you can, raise your hand and say if you don't want to, or if you want to. I don't know which one. I guess raise your hand if you'd like to take if you would like to take a break. Yes, is that easier? If you'd like to take a break in 10 minutes, could you just raise your hand and I'll let Chair Khan know.
So anybody,
So it looks like you've got, at this point, you've got a simple majority for folks wanting to take a break in 10 minutes.
Okay, great. So we'll do that. So let's at least get started and then we'll take a 5-minute break. So let's open it. Who is the first commissioner on line to speak on the items?
So I was going to go to Dr. Barron, but Dr. Barron, I did capture your notes. Did you want an opportunity to kind of restate it? Otherwise, we can move on to Dr. Packham.
You can move on.
Okay, great. Dr. Packham?
Yeah, I just had a couple of thoughts. First was, I agree with Howard's comments about limiting this to prices and costs. Quality and quality reporting are their own kettle of fish, and I think our focus should be more narrowly on costs. With respect to the entire set of items on this list, my preference would be to limit the scope of this bill to the all-payer claims database and leave the others for another day. And I think that would be about it. I would not be in favor of us expanding our authority.
All right, next commissioner.
Okay, it looks like Dr.
So,
Sloan.
sorry, before I go, so Dr. Packham, so You have any other comments on any other items on that bill draft, or this is your only comment?
That was my only comments, yeah.
Okay,
The
all right.
only other thought I had that maybe would like to put it out there, since there's people smarter on this than I am. I don't know if there's any way on the all payer claims database to bake in incentives for the self-funded plans that presumably wouldn't be required to report on this. I'm a member of PEB, and that's 70,000 lives. And I don't think that self-funded plan would be required to report. So if there's others that are more knowledgeable of how we could put some carrots out there, not sticks, but incentivize the self-funded plans to participate, I think that would be at least worth discussing.
So if I hear you correctly, you would like to see that included if it is doable and if others agree to that?
Yeah, and particularly if there's some other models out there. They can't be required to do it, as I understand it, but.
That's correct.
Yeah.
All right, okay, so next, Commissioner.
Thank you. This is Tony Sloan for the record. A couple of things. I agree with Commissioners Barham and Packham. So far, they're the only ones that have commented about the need to narrow the transparency BDR to an all claims database and inventory the data that already exists. With that comment by background, let me make a few other specific points. In the legislative intent, I'll go from top to bottom, Sarah, this way you can track with me.
Okay.
Yeah, that's helpful.
Yeah. It seems like that first paragraph on legislative intent is missing healthcare insurers.
Healthcare industry.
Right, we said we would be broadly focused on all entities within the healthcare system, macro system. And so insurers certainly needs to be included there.
Okay.
If you scroll down to require a report in the transparency measure, I'm sorry.
Hold on.
Yeah.
Right, is that what you're intending to capture?
Yep. Yes,
Okay.
thank you. Under, I would comment that on the inventory, there's, as has already been mentioned by Commissioner Barron, there's a whole bunch of things that are already available. We should just make sure we know what they are. On the report, which is the next paragraph, there's more, I have more questions than answers on this as it relates to the way it's worded. And I think Commissioner Barron highlighted them as well. Who is going to be assessing quality? How are we defining it? Hospital quality reporting already exists in elaborate ways through CMS and Nevada Hospital Compare and other things. And so I worry that as we've gotten scope creep, we have not been definitive about the kinds of traction points that already exist. And it's this kind of mishmash of things as a result. So again, I think we need more specificity there if we're going to support that. On the consolidation paragraph, again, what is the purpose? And I was vocal on the last meeting about we already have a mechanism for mergers. Commissioner Barron mentioned this about reporting required by the AG's office, not by DHHS, I think is the way it's been worded here, and I would continue to follow the way we have it. These are transactions that follow the way that the law has been written. On report of the use of emergency funds, 2 paragraphs down, not sure why this is necessary. Reporting requirements come with the acceptance of COVID-19 funds. We've got, our auditors have come back within the last week and said, hey, we're following the rules that have been established. Why are we adding another layer for, these are already granted in regulations and in the legislation that's available there. I'm not sure why we're even adding another layer. As far as the administrative penalties, aren't there administrative penalties already available in NRS? I think there's already existing language there. We should probably make sure that we go back and take a look at that.
Mhm.
Going down further, data related to patient healthcare costs. Again, I want to go on the record as saying I am supportive of a BDR that focuses on an all payers claim database. It's this additive stuff that I think detracts from the intent of what we were initially interested in and has muddied the water and made this a very cumbersome document. Data related to healthcare costs, I think this can be included in the all payers claim database by negotiated rate. And hospitals have insurance premiums and cost sharing information already. We need to understand that inventory piece. And then as we move down to transparency, this whole section, as you guys know, this is still in the courts. We're not even aware of what the outcomes are going to be. There are several things under appeal in federal court that impact this section. And again, the issues of we don't even know what we don't know yet. It hasn't worked its way out, and we're putting things into a bill draft request that I think is problematic. On the next page, expanded authority. I think this is self-aggrandizing. When we've done our work for patients in the state of Nevada, I'm happy to entertain additional authority for the Patient Protection Commission. I think this is self-aggrandizing at best, and we should wait until we actually get some work done. And that whole section for me is a non-starter. I think that's. Oh, on the last point, the administrative penalties, which is the very last paragraph. I'm not sure how awareness of this translates into better healthcare outcomes. Again, I'm going back to we're here to serve the public and certainly making sure that we're focused on the access to cost and the quality issues are relevant, but administrative penalties, I'm not sure I get that paragraph either, but those are the majority of my comments, Chair Khan.
All right, thank you very much. I think we are at 11:01, so we'll take a break. So we'll get back at 11:11 or 11:12. So we'll take a break for 5 or 6 minutes and come back. Thank you.
Thanks.
Yeah, I'm back. Let's get back into session, I think. Yes, sir. Hello. So we are back on, everybody. Is everybody back on for the quorum?
Sorry, okay, I can hear you. Are we all back? Yep.
Okay. All right, so moving along on the language of the, back to the second BDR that where we started earlier. So who's the next commissioner would like to speak?
We've got Bobette.
Go. All right, go ahead. Is Bobette on?
I think so.
Are you on mute, Bobette?
Yes, if you don't mind, I'd like to wait till some of the other commissioners weigh in so I can.
Okay. You know what? I
gather
actually went out of order, and it's supposed to be Mason. Mason, sorry, Mason.
No problem. You had me trained already, Sarah. So I was like, okay.
Sorry, yeah.
I kind of like to wait too, but I'm up. But I'll do that. No, I think this particular one is going to have a little bit lengthier conversation in regards. I think there's some very good components of the BDR. Quite frankly, I think some could just stand on their own, as I heard from a couple others. I think just going through, agree with a lot of the comments that have been said so far. I think as far as asking for some more authority, I think we just got to prove ourselves. And I know we got a lot of work, and we've been working hard this last 12 months, 8 months. But once this legislative session passes, we will have some time to really catch our breath and focus in on what I think are some of the quality dashboards that I think we can produce internally without having to regulate ourselves or the industry. So I think when we go back to the first couple initial meetings, I would have liked to seen some subgroups or some committees working on some of those, and maybe quality could be one of those that we can internally take some of the materials that are out there and bring them into one central source. So definitely feel like quality needs to be a focus. I agree regarding some of the COVID dollars. When we sign up and receive those dollars, we say that we will comply with all federal, state, and local guidelines for that. So I'm not sure if we actually need to do that because it's a little duplicative. And I will tell you, after all this is said and done, there will be extensive auditing of the dollars used throughout the country. So those are kind of my initial thoughts, but I think probably a little bit more refinement in the second round of discussions as we narrow down some of this language. But again, I think a lot of these components could be broken down into some smaller pieces moving forward. I also, I noticed some of the, the mergers, acquisitions. It would be good to be notified from some of those other agencies, but I'm not sure if the Patient Protection Commission is that extra layer. Maybe a little bit more connecting with some of those agencies on notification where legally able to, or antitrust type of things. It would be nice for this committee to be apprised of those, but not an additional layer of review, just because I think that gets a little bit beyond our scope. But I do think it is worth informing the committee. But so those are my initial thoughts, Mr. Chair. I'll probably have more as we continue refinement as in our second round of this.
All right, thank you, Mason. Who's next on the line?
I've got Commissioner Bond. If you want to pass, I can go to Mr. Shaner.
I'd like to pass and come back. I've spent a lot of time on this, and so I would like to get everybody's thoughts and then weigh in before we go into the second round, if that's okay.
Okay.
Sure.
Mr. Shaner?
Sure, thank you, Mr. Chair. A couple thoughts, and as I'll be looking at another computer here, just staring at the notes that I made. With respect to the transparency measures, it talks about insurers, and I think Commissioner Slonim referenced it. And I'll say again what I've said in previous meeting. NRS governs fully insured payers, doesn't govern self-funded payers. However, the hope is that self-funded payers would also comply and go along with whatever we pass here. Probably a moot point with respect to identifying with insurers that be fully insured and self-funded, but I want to make sure that it's clear as to what the intent of this commission's purpose is that would be collecting information from all payers, not just fully insured payers with respect to this. I agree with the comments on healthcare quality as to what metrics. That's very broad and open, and I know the chair last time spoke about Leapfrog and other entities that are out there that look at different quality metrics, but that's very broad. With respect to consolidation, again, other agencies are currently tasked with gathering this information. I don't want to be duplicative, and I don't want to make it cumbersome to the extent that certain providers might merge. And no disrespect to Dr. Barron, but if Dr. Barron were to merge with another pediatric gastroenterologist, that's a one-person group. Is that something that we really feel needs to be reported up through this? So perhaps if we do go forward with something here, maybe some certain dollar threshold or size threshold. I know oftentimes with respect to bill drafts and bills, when they're put forth, sometimes they're based on county and population size. Maybe that's something that we could consider here. I agree with the COVID dollars. That's redundant. Those dollars are already having to be accounted for elsewhere. With respect to the hospital price transparency on the second page towards the bottom, I personally don't know what CMS hospital price transparency final rule says. So for us to sit here and vote that it should be codified into Nevada law, I think would be a little premature, given I don't know if anybody else knows what it says verbatim or exactly, but I do not. And then when we talk about the all player claims database, last meeting I had shared that there should be some regulations about how the data is submitted And I know that in other states, California and others, they've used the common data layout. I am by no means an IT expert that can sit here and tell you exactly what that is, but I think we should put some sort of parameters around how that data should be submitted to the state and how what the expectation is. Otherwise, it'll be a free-for-all and probably not best utilized. And then as we go forward, I know we spoke about how this would be funded, but I also just have concerns around where this will fall out with respect to priorities for the state and funding, and if the personnel will be there to maintain it long term and produce what we envision it being able to produce. It has to be paid for in some way, and I know there's information here about what was done in 2019. I just worry about how that would be funded go forward. Thank you.
Thank you. Who's our next commissioner in line?
Okay, Flo.
Thank you. I agree with a lot of what's already been said, specifically with respect to Dr. Packham's response that we should narrow the focus of the transparency bill to an all payers claim database bill. There's a lot of work that would need to be put into that bill alone. And I think that's the starting point that we need to have a better understanding of what the cost drivers are in the healthcare system overall. So for that reason, for many of the other things, I agree that those are important things that we could look at, but I think those should be in a separate BDR and separated out, including, some of the consolidation issues, some of the reporting requirements. Those could actually fall under if there was any movement on additional authorization for the commission, that we could put some of the reporting under that category and within that BDR. And so those are ones. The only additional comment that I would make is back at the confidentiality piece. There was alternative language that was being proposed to the original language. We would have concerns about the alternative language, that it might be too loose, and that we would just want to make sure. I think we feel more comfortable with the first set of language that was being proposed, because it's more specific to protections around confidentiality of certain types of information. It's not super specific. I think there was a lot more work that would have to be done, but I think we would feel more comfortable with the first set of language there on confidentiality.
Okay, thank you.
Mm-hmm.
Who's our next commissioner?
Jessica?
I agree with almost all the comments that have come before. I like that idea of narrowing the bill to the all payer claims database, because I think some of this other stuff is really pretty controversial in some ways. I like the idea of the inventorying. I think one question on that inventory is, where will that be reported to, or who will be reporting that? Is that DHHS? I like what Commissioners Packham and Schoner talked about with the self-funded insurers. I don't know if there's any way to, that carrot. I know there's no way to mandate that, but how do you, encourage reporting so that we have a full view of our entire system? I agree also with some of the reporting requirements that we're talking about, that might be a little bit of the cart before the horse. Until we have that inventory, do we really know what should be in the report, or what would be good to report on? Same thing with the emergency funds for COVID. I agree. I don't know if that really makes sense to have that in here. Like the other commissioner said, I would love to know more about the consolidation piece. It seems like we need to have way more specifics on that to really even understand what that means. I also don't support expanded authority right now. I believe in more incremental change, and I feel like when you do these big jumps, sometimes there's a lot of unintended consequences, and they take away that ability to be more skillful in bringing the commission forward. So I think those are my thoughts. Thanks.
Thank you. Next commissioner in line.
Yarleni.
She on mute?
Yarleni.
Sorry, yes, I was on mute. Okay, so I think that, yes, this bill is very extensive, but everything that's in here is pretty important and everything is related to transparency. My question on the all payers claim, what are we trying to do? I thought that DDHS was already purchasing this type of database. That was my understanding I think in the last previous meetings. Is this all payers claims database part of the bill? Is that just like making it a law? So how is this affecting what is already happening at DHHS?
All right, thank you. Our next commissioner.
Now we're back to Bobette, but oh wait, I have some thoughts too that I definitely want to share with the commission. And first, I think I want to bring back everybody to our first meeting that the governor came and addressed this commission, and he made it very clear that he was not looking for a 30,000 foot, recommendation, but he really wants specific recommendations, and he wants the legislature to be anxious to kind of tackle these problems. And really, when he talks about the vision of this commission, he brought everybody to this commission, and you all got your appointments because he thought that you were the expertise that were kind of the brightest minds in the state. And so to tackle all of these discussions, and I would be remiss if I didn't pause for a moment and remind this body that over the last several meetings that we have had, when you talked about this language, there was no opposition. You all agreed to move forward with the concept of this outline. You all agreed to move forward with a lot of these details. And I'm actually just hearing now for the very first time that you do have concerns and you do have some opposition to this, but where's the transparency in that process? Because I told all of the commissioners that I would really want to make sure that I heard from all of you. I reached out to all of you, made sure that we captured all of this language. And now you're talking about gutting this bill, gutting this language, not moving forward. I mean, we're all talking about this kind of conceptually, but I didn't hear any of this. I didn't get this feedback from any of these commissioners who raised these concerns with opposition to this language now. And so this is happening for the very first time. So I want the public to be aware. I want everyone who's watching this, our legislators, our governors, everyone who is watching our work to know that in between the last two meetings, I did not get any feedback from you all on this. And this is the first time I'm hearing about it. And it's kind of taken me a little bit by surprise. And, we were all assigned here to do the work, to ask these tough questions, to put forth these kind of bold ideas, really to address access and affordability and quality of healthcare for every Nevadan. So I would be remiss, Mr. Chair, if I didn't just stop and say that I want to make sure that the record reflects that this is the first time that I'm hearing some of these opposition points. And I have not heard from these commissioners in between our last meeting. And most of this language, with the exception of, I think, this alternative language, reflects the format that we had at our last meeting, in which nobody raised any opposition to. So publicly, everyone here was, this is the first time you're being raised between now and 2 weeks later. So the only thing that's been changed on this language, and maybe I should have started with that, was adding in this alternative language. I think that there was some concerns about the mergers and acquisitions and the AG's role. So wanted to make sure to make everybody feel comfortable that we added language here that added that the intent was to keep the AG's independent legal authority and then allow DHHS the ability to make recommendations on policy. So there is no change in that, but that was just there for clarification purposes. And if you can see here, this is not actual language. This is just to make sure that LCB, while they're drafting it, understands that this bill was not intended to change any legal authority of the Attorney General's office.
So Sarah, if I could respond, I don't know about this whole lack of transparency or whatever. I think I have not really understood a lot of this stuff that's been in here. I've asked for more specificity, and I think that today is when the rubber meets the road, and there's stuff that feels very comfortable, that's well vetted, such as the all payer claims database. Some of the other stuff is like, what does that look like? And I think that those questions have been coming up. And so I wonder if you could address that, or that's
sure. Yeah, I think that's great. I absolutely think that the conversations and the meetings that we have had so far does reflect that everybody seems to be in agreement with this kind of conceptual idea of mandating, reporting for transparency purposes to, at least to get this bill draft started. And so my understanding was all of you were on board. I mean, this was passed initially, the concept was passed by all of you unanimously. And so this is just one step in the whole process to move forward with. And then, my understanding is that we have to make sure that this goes through the legislature. So there will be a process for this to be further deliberated on and discussed in detail. But you all agreed on a lot of the language from the very beginning. And it was admirable. It was great. It seemed like, everybody was kind of coming together with an understanding that we want to address access and affordability for every patient, and that we were all on the same page. And then to now have things being changed, or at least some of the components of like just gutting it is new. It's new to me. And I want to make sure that I put on the record that was.
Hold on just a minute. I'll have a comment. Let's finish, please.
So I just want to make sure that I put on the record that I sought the feedback from all of the commissioners. I've embraced every phone call. I have tried to get alternative language to make sure that the work was getting done. If you all wanted more specificity, if you wanted more details, then, seek it, work with me. And I've taken every single phone call. I've asked for alternative language. I'm asking how to propose it. And I've rolled up my sleeves and tried to make every single conversation happen to anybody if they wanted to ask for it, because the intent is to make sure that we captured what you all wanted to accomplish. And then to be told now that there's so much opposition to, some of these provisions is just not my understanding of the work that we have done so far.
So anyway, so let me comment in on that. So appreciate your input, Sarah. So the bottom line in my view, obviously, is this is a work in progress. So we have all known all along that we are inching forwards in narrowing down the language of the bill draft. And I have, and everybody else, I think, has a clear understanding. We are agreeing on broader principles or initial language as we moved along. And so there was some language that was previously, or subjects or items of concern and interest that were discussed previously as a broader outline and draft. And I've always mentioned, given the time constraints, that this bill will come back, draft will come back, we'll have an opportunity to fine tune it or adjust, modify, or change if we need before it goes to the final version of it. My view is the fact that a lot of commissioners didn't chime in between the last meeting and now to consider their amendments or new developments or understandings as they always evolve based on more input everybody gets. That's fair and concern, obviously. But the meeting now is obviously to address the same issues for those commissioners who have not chimed in the interim, but have thoughts for this open meeting to be considered and looked at. And I think personally that the commissioners have a right to chime in their final version or today to come up with the language that may or may not have been their view the last time, that may have been change in views, or views evolve till we get to the final language. And I can fully understand. The only thing is I would suggest and request moving forward, it would be helpful if the commissioners send in their thoughts and views ahead of time so they can be incorporated by Sarah in the upcoming meetings, that since our last meeting, these are the new versions that have been brought forward, or amendments or changes in the views of commissioners for this meeting. But I think what is happening today is we are sort of fine tuning the language, and in some cases are not in agreement with some of the thoughts that we had before, based on perhaps additional evolving understanding of the subjects and the consequences of the language that we may have suggested collectively in the past. And I think everybody has the right to kind of evolve in their views and opinions as we move forward. So I think this is a work in progress, but the work in progress has to come an end, hopefully today, so that we can meet our deadline for the final language that everybody agrees upon. So I think whatever is being proposed, and I've taken my notes, these were all discussed and were proposed as language with the understanding that the next meeting we'll have to finalize our fine tuning of this subjects. And I think that's the work in progress going on today. So I think as much as we would have desired to come for this information or input come in earlier as requested, and it didn't come in earlier, is obviously a concern moving forward. It makes the job of the executive director a little easier to say, okay, since last time you have made these changes, and she would have put it into the draft form for us to discuss again today. So I think we are moving forward in terms of evolution of our opinions and views before we find, which we all have a right to do so till the last moment and make our suggestions known. So
I also think that we should have a right to have our opinions changed during the meeting. I think Commissioner Barron made some really good points that really changed my views. I mean, isn't that the purpose of having a meeting? So I would prefer to not think that, you know, I'm doing something weird behind the scenes when like we're having a meeting talking about our opinions. So.
Yeah, so I fully appreciate that. And that's what I've just, I think, said enough about, that everybody has the right till the final version is brought in or agreed upon. And I think we need to come to the final version of language today, whether we assign some of the language or redo some components of the language. And as long as we all agree to that, that would be the final language to go forward because our deadline is tomorrow on at least these two bills. We did agree on the first one, transparency. We had some changes, modifications, and we are going over that deliberation now for the second bill. So I think we need to move on and get everybody's input and go through the second round after Babette has commented and see where we narrow down everybody's opinion and views before a final bill draft. So having said that, I would like to proceed in the interest of time and see, Babette, I think you're next on the agenda now.
Thank you, Chair. I appreciate it. And thank you for your comments, Sarah. I think we're kind of trying to get it together as a commission where we feel like we can understand each other's perspective. And, you know, we're new, but I do want to make a couple of points here. Transparency is what we're asking for. We're not asking for laws to change. We're not asking for new restrictions on the way things operate. We're asking for information about what's going on. The stuff that was presented by Jamie King is about how you learn what's going on. We have virtually no information in this state that's consolidated and collected in a way where we can see how many physician practices have coalesced and consolidated, how many hospitals have bought surgery centers and physician groups, how that impacts existing statute about laws about what can be consolidated. So I don't know how I think my two main points are, it's difficult for us to move forward as a coalition or as a commission without information. It's difficult to be in meetings where we talk about how to collect that information and there's an unwillingness from the commissioners to even collect the information or to make the information easily available. I think that makes it really hard to move forward. I was listening carefully to specific problems with the requests for information, and mostly what I'm getting is, you know, we're too young and we're not, or we haven't earned it. This commission doesn't meet for 3 more years in a way that can work on data. The bill drafts due today go to the 2022 legislature, right? They have to get passed. And then if we don't do anything in 2022, we don't do anything until 2024 to give ourselves a way to look at data. So I'm very concerned about the inability to at least get some foundational building blocks in place so we can choose and move towards the patient protection issues that I know many of these commissioners are extremely interested in getting to. I don't think we have nearly as much organized information and easily accessible information as a lot of other states that are trying to do this. I'm positive about I appreciate the support for the All Payers Claim Database. That isn't even something that we were pushing, but I know that it's an interest in the state to have one, so we're supporting that. We're supporting the telehealth bill for the same reasons. So I feel like we're coming to the table on trying to get some of these issues addressed, but I'm concerned today that there's the main reason to not move forward is I actually didn't hear any reasons not to move forward. We just don't want to. We just don't want to. So I would like to get some specificity on what we can accomplish as a group, because I think that there is some good information in this, and I really appreciate the feedback about what is not okay so that we can figure out how to adjust it if possible. But I don't understand how to move forward if the answer is just we don't want to do it. So could we go through some of the actual pieces of the...
Yes, please.
Okay. All right, so I tried to take some notes, and I know there was a lot of input. All right, if we go back to Jamie King stuff, I'll try to go forward in this bill in order. I'm sorry, I was taking notes and then there was just a lot. So let me pull up my version, Sarah, while you've got your version up.
Okay.
Thanks for your patience, everybody. I'm fine with Dr. Sloanim's comments that we should add, healthcare insurers or healthcare payers on there. That was always the intent. And that's exactly what the payer claims database is. So it's kind of embedded in the piece that the rest of you are supporting. Dr. Barron's comments about we don't have data about quality, like what is quality in the provider group. I kind of left that open last time because we hadn't really gotten a presentation from the specific provider groups. The hospitals do provide their data. They do it through the claim itself. So the claims go into CHIA, the Center for Health Information Analysis in Nevada, and they pull out from there quality indicators from AHRQ, which is a national quality program that's been going on for over a decade in the state. But then those reports are never, in the nation, those reports are never then lifted into a data set that anybody can consistently review or compare to other areas. So there's no process to take what is going on with our AHRQ measures and compare them to other states. That is something our commission should be doing, is seeing how we're doing on those quality on AHRQ measures for the hospitals, instead of just having them sit in a report somewhere. So that would be good if we could make progress on that. On the physician stuff that Dr. Barron is talking about, there are several groups that are there's several databases that can be used, and I was leaving it to get input from the doctors as the experts on this, but even though they don't really use AHRQ, they use HEDIS, they use CAHPS. There's a couple of national initiatives to provide more data about it. It's not just outcomes, it's process, it's patient experience, it's utilization. And so I think that those databases do exist. I would like to just put in the record that HEDIS and CAHPS are frequently used, probably universally used in Nevada, but we could document that. So I think that would be additional content that we could definitely expect. I think we're all in agreement, or mostly in agreement, about an inventory. And I think that that would help us get to the point of, okay, we really don't have enough data about providers, you know, in certain specialties. But I think that, so I won't need to dwell on that because I think that we do have support for that. Let me move down. I don't understand how this is scope creep. I don't think that we had, I think we define our scope. So I don't think that there was, I don't really understand the baseline for why, if we don't have any action, how is there a scope? And if we don't create a scope, how do we have scope creep?
Sorry, Babette, what specifically are you addressing to here?
I'm addressing, somebody said that we should get a report each year summarizing healthcare quality in Nevada. And one of the commissioners, I don't have a name here, said it was scope creep. And I'm not sure why it's scope creep. I think it was Dr. Slonim. So I'm just confused about that.
That was me. The comment about scope creep had to do with the BER in general. So it's about the advancing of the PPC powers. It's about all of the other things beyond the all payers claim database. That was what the reference was.
Okay, so it's the whole bill other than all claims payer database, although you support the inventory, I believe. All right, so consolidation. I thought Jamie King did a really good job of talking about why we need some data on what's going on in the industry, because it's a huge market impact on price. And there's been huge action in Nevada, not just consolidation of physician groups, but the introduction of private equity money in our state is dramatically altering what kind of bills, what kind of networks, what kind of access patients have. And I think that we have zero insight into that. So I think having the commission at least have the ability to see merger data, not change the AG's authority. A few of you said the AG already does that, or an agency already does that. That data never appears anywhere. No one else ever sees it. And the reason for this commission is to, in my opinion, is to start being able to see what's going on in the healthcare system in Nevada. And it was a whole. Before this commission was created, there was no entity doing that, bringing together just the disparate parts of the system to be able to see the whole picture and see where our opportunity is. So I think that this is a fundamental building block to get some eyes on industry consolidation. To the major issue, I think Commissioner Flo Khan, the confidentiality language, I really think that we need to keep working on it. Our alternative language, I thought, captured most of what you want, but not all of what you want, because I think the beginning line of your language saying information acquired pursuant to this section shall be confidential and shall be exempt from disclosure, that is so broad. I mean, disclosure, then what's the point? What's the point of collecting anything if nothing can be disclosed? It doesn't move transparency forward at all. The hospital transparency suggestion that came from, I think, Director Richardson. I know that the national law about hospital transparency is not yet being implemented, but it certainly has been passed, and the hospitals have lost in the court case and now are in appeal. So to say it hasn't been quite worked out yet, I'm not sure that's true, but I would be happy in between now and next meeting to take a look at what exactly is in that law, as Commissioner Shaner suggested, and see what is in there that we don't have now, or understand exactly what the concerns are. I'm sure the hospitals have concerns because they're fighting it. So I kind of feel on the fence about that one. Maybe that isn't something that's urgent. Sorry, I'm getting input that I need to shut down from my real job to keep moving through this document. All right, and then the role of the Patient Protection Commission. I think that's critical. I think if we don't have authority to look at information that's come in, and we don't have the ability to look at patient access, healthcare costs, and systemic price drivers, we can't do very much that's effective. We're just going to be listening to random reports with no database and no foundation and no way to create a roadmap. So I'm sorry that there's a commissioner that's calling it self-aggrandizing, but I really felt when we got 3 BDRs that one of them really should go to making sure we have making sure that we have the ability to look at the transparency work that's been done to date and the ability to move forward on creating some good steps for the state. And that does require some level of capacity to receive information. It's possible, if we talk to LCB, it's possible that we already have that access, and maybe we could go back and check on that. But I don't see it as self-aggrandizing to help define ourselves. And I was actually told when I agreed to participate in the commission that one of our roles was to help define how. So I believe it's important for us to help do that. I think that's it. So I would like to continue to work on some of these issues, and I'm more than happy to work with anybody on them to get to the next step. I'm not sure how we move forward from here to the next meeting on some of it, but that's my first round of comments.
Okay, is there anybody else on the first round? Sarah?
That concludes everybody on the first round, so we can go over to.
Let me, before we move, so I'm the last one to give my, as always, 2 cents, which is moving to 1 cent worth slowly. But anyway, having said that, so a lot of thoughts in the first round on a lot of these subjects, and there's a whole list of subjects. So as far as I am concerned, as I keep emphasizing personally, is a lot of this, what I've heard about the commissioners in the first round, that perhaps the choice of words in some cases may have sounded strong. Obviously, we all have a right to express our views strongly or not so strongly, or superficially, etc. But having said that, I thought there were some good thought processes. Everybody seemed to have a sense that there should be some data collection, and the question came up at, should we be, for example, that was not specifically mentioned, in compelling other agencies like DHHS to give us the information, which if whatever the information they collect in various aspects of delivery of service from hospitals or others, that is available to anyone and everyone who may be interested to get it. And PPC could be one of the recipients of that data, because that data is technically public record. So my view on that was that to compel them to give, they can give it to us if we request it, whatever is in public data. What is not public data under what is statutory or regulatory concerns, obviously is not public data, and there will be certainly a process to pursue that if we are interested in that data, key to our deliberation of activities. See, and there's always the concern about PPC powers, etc. My personal view again on that is that we are an evolving commission. We may end up getting a lot more sense of direction of what we need to get into our quote unquote powers. And it was mentioned in one of the last meetings, whether we need even subpoena powers. I have some concerns about that. The areas where publicly available information, whether it's on quality or claims, et cetera, that can always be requested by us, and we can get that and discuss about it. The focus right now is what we need to include in our second bill draft, so we don't get bogged down into a lot of this discussion that we have had and good input from various commissioners, whether there is an urgency or emergency to incorporate some of that element today into this. There'll be opportunities to move forward, and there are other ways of getting this, some of these subjects into the legislative process, the private individuals putting amendments, etc., to bill drafts. There are a lot of them are coming up or will be coming up in the upcoming session. So they could still be addressed in that context. So my other concern is, give me a second, please. I'm looking in my notes. The issue of, 2 issues were also talked about compelling or requiring information and merger acquisition. And I've opined that in the past, the AG's office looks at it, and if it is going to impact the patient's accessibility by a monopoly in certain acquisitions and mergers, they look at that, and I suspect whatever their determination is, perhaps some of that, the AGs on the line, they can tell us who has access to that data, and usually they publish why they have not allowed a certain merger or allowed a certain merger. Usually it happens in larger companies and organizations, and not much of anything is in that context on smaller groups in town. So one could look at that, what the AG's determination vis-a-vis impacting the access of patients by those mergers is going to compromise that. Is monopoly going to hurt the pricing elements? That's all discussed at length in that, and maybe they can share some of that information when and if they determine that it could be of adverse consequence for patient access and indirectly or directly patient pricing on those components. There's a lot of discussion about quality data and being submitted, and I've also mentioned that again. My view is still the same. There is a whole bunch of agencies monitoring quality data vis-a-vis the deliveries, whether it's the managed care organizations and or the hospitals, and that information is all generally public record. There isn't enough data on individual physicians and providers. And that's a huge element because there's large slew of providers in various specialties. And how does one get their quality data into which departments? There is some oversight, underlying some, through their licensing boards. They get information on individuals, et cetera, on the quality metrics. And it takes time for them that to catch up on the quality of delivery of service by individual providers in that specialty, whether it be nursing, behavioral health, et cetera. They all have their boards that oversee them. So that to some extent is being taken care of now. How it gets incorporated is a whole different issue under our situation. So I think generally, I am personally not for a whole lot of massive regulatory authority, especially if we see that a lot of the information available is still available. It's just how to get access to that information from various agencies so we can also look at it and then give our opinion that this information is not adequate or we need additional to make sense of it, and then see what can or cannot be done. I don't want to take too much time on this before I give everybody the opportunity to speak freely on the second round of conversation so that we can narrow down some of the language that is evolving by consensus or majority as we finalize the language being proposed. So let's go through the second round.
Mr.
Sarah.
Chair, Mr. Chair,
Yes.
This is Mason. I apologize to interrupt. I know you're going to, it would be helpful to me because again, I think there's a good discussion. I think there are things that many agree on. Can we color code this a little bit to park some of the things that we all agree on? I thought there was some consensus on the all payers database, a couple other things. Could we put those in maybe green, yellow, and red? Because I think some are going to have a much deeper conversation. And just looking at the time, I know you would like it to keep us on time at 12:30, but is there any way that we could quickly go down just the bullet point, the big bullet points as to say, is everybody good with this? And then skip on to the next one and color code it? Just because I think we're going to have the same conversation again without some back and forth dialogue. Just a suggestion.
That's a great suggestion, Mason. I agree with that. And let's do that, Sarah, with your help. If it's not too much in doing color coding, as Mason is suggesting, but I suspect you are the tech guru, so you might be able to do it.
Yeah, no, I think that's fine. That's a great suggestion, Mason. I'm happy to color code. I think that I don't know what I've highlighted are just some of the areas that have been mentioned, but.
Oh, that's helpful, Sarah. Yeah, well, I see where you did that. Thank you.
I also just mentioned, this is Flo Khan, that some of the stuff that's in some of the bullets would be in an all payers claim database, because I think, going through all of this, the all claims payer database is going to encompass all aspects of the healthcare ecosystem, bringing in the reporting of data that we want to collect. It's going to talk about the cost drivers within the healthcare system. I mean, there's a lot of information that's going to be contained within that, which I think is all part of what we're looking for. And even the confidentiality provisions, that would also be a part of that all claims payer database. So we might want to highlight some of those. I think one of the things that what I was looking at this when we did our first round was really going through and saying, okay, there's all of this stuff that we said we want to consider as part of transparency. But then I thought our purpose was like, we've got to narrow down for a BDR. Like all of this stuff is important. All of this stuff is things that we've agreed need to be looked at, but putting it all in one bill could be problematic. And so a part of it was, at least from my viewpoint, was we need to take some of this out and put it in a separate BDR. But the real focus of this particular BDR, if we could all come to agreement on, was that all payers claims database bill. So that's kind of what I was thinking. And then some of the others. So for example, breaking all of this into different BDRs. So the consolidation piece specifically with the hospitals could be a separate BDR. You could have the role of the commission be a separate BDR and really move forward on something. And those are things that we want to do and move forward on and talk about, but they really need to be pulled out of then having an all payer claims database bill being separate. And that is huge in and of itself.
So without violating our process of everybody having an opportunity, just to comment on that, we need to narrow down our language on this bill as closely as we can, and subjects, if we look out for a third BDR, as I said in my opening remarks, let's narrow down the language that we want in these two BDRs, and there's a whole slew of subjects previously discussed and some evolving in our discussion today that will have to be considered for the third BDR. And I'm afraid a lot of subjects being considered for third BDR after we have narrowed down the second BDR's language will be, as I said earlier, repeating myself, Pandora's box to see what do we need in that third BDR for the deadline. And then that will be a whole big discussion. So let's focus on how do we want to have the language, if we may, on the second BDR. And if there is some consensus to eliminate some subjects from this particular language, then we can discuss those after this has been agreed upon for a potential third BDR and see where we go with it today, if at all.
But that's what I agree with Flo. I mean, that's exactly what I was thinking is each one of these topics is worthy of a whole BDR. My BDR for the Northern Board, I've spent at least 1,000 hours on NRS 433A, right? And I think that's my concern as a commissioner is just rubber stamping a sentence that contains a world of change for Nevada. So, I mean, I think that goes back to wanting subcommittees and really wanting detail. Maybe I'm someone who wants detail, and that's why when we're sitting here going, oh, are you going to support this? It feels pretty uncomfortable. And so I think all the commissioners are saying, yeah, we feel really comfortable with an all payer claims database. Some of these other pieces, but other stuff is like a one sentence on pretty drastic change.
So let me do this, please. Let's get back to our orderly one-on-one commissioner discussion so that everybody has an opportunity and we can hold our views till our turn comes and speak as much as we want on what we want to do or not do. So if I may, get us back to our system of starting with whoever the first commissioner wants to opine on this BDR language for today for finalization or near finalization of the language for the second BDR. So if we may start with whoever's first being recognized by Sarah, we can go from there. So who's the next one, first one to opine in the second round on the discussion?
So we're going to go to the second round. Dr. Barron, we'll start with you. And then can I just pause for that? I'm not sure how we want to color code this to kind of help with the flow of the conversation I'm highlighting it. And Mason, if I can just lean on you a little bit, I know I did the yellow is kind of the items that I think are ones that there's been some deep conversations on, but what is your suggestion on the color coding? What makes the most sense here for you?
Well, thank you, Sarah, for asking. Yeah, this is, I agree with everything that's been said. I think many of this stands on its own, but I have just heard, and I'm not the chair, but I've heard the all pairs. I'm
talking about the just the color coding portion of it because it's like, well, I don't know what makes it easy for me or for you guys when you're looking at it.
Where we've had some very in-depth thoughts and feelings. And I appreciate Bobette kind of bringing it home for us on some of the intent around a lot of the language. So that was helpful for clarification. But there's definitely, I think there's things you can put in the red that I think will have to be parked in deeper conversation. But the green is definitely where I think there's more agreement, and the yellow is kind of those gray lines.
I think it's, well, like, I'm going to make everything yellow. And I think if there is something that somebody wants to suggest to pull out, then I will then change that to green. So how about we go from there? So everybody's on the same page. Yellow is everything that I have highlighted so far that has elicited such robust conversation. But what I'll do is, if there's a suggestion as a second round, is I will change those areas to green to indicate that you want those pulled out or a part of another action. Does that make sense? Okay. All right. So Dr. Barron?
So sorry, quick, sorry to interrupt, but it's, for some reason my iPad is showing lower battery, even though it's on power. So Sarah, could you kindly send me the information on click here to dial in? I can do it from my other gadget.
Sure. Let me just send that to you really quick. Hold on.
Thank you. I don't know why it's on power all along.
All right. Sorry, guys. It's kind of important our chair stays connected. So let me pause for a moment and send this to him.
So in the virtual meeting, you had sent a panelist
right.
email.
Right. Okay, let's see. All right, I just resent it to you, so you should have it.
Okay, thank you. So far it's working, so let's continue.
Okay, so Dr. Barron, we'll start with you.
Okay. Just I would, by the way, I would echo what Commissioner Flood said, which is that I sort of relish this opportunity to meet, as we've been doing, to kind of hear what the other commissioners are thinking, when in the spirit of a to trying to adhere to open meeting laws. I'm not having any ex parte communications with anybody outside of these meetings, and so while I appreciate the need for Sarah to collate all the information, I'm learning stuff today that I would not have gotten otherwise. So I think it's important for all of us to be able to sort of share and modulate our opinions at these meetings, even though that I understand that the hour is late and the time is late in terms of our timeline. Looking at the language here. Again, I'm fine with the first paragraph under legislative intent of proposed bill as it has been modified. Transparency measures. I would agree with that first paragraph. I like the idea of that where it says require an inventory of the currently recorded healthcare data. I'm just not sure what that all involves, and so I think it's just kind of broad, and I'm just not sure what LCB will do with that. But I like the idea of having reported health data so that this commission can review. And if there's anything that we can't get enough of, it's data. Requiring a report each year to summarize healthcare quality. I've made my mention about my concerns about healthcare quality, and for those of you that aren't practitioners that are involved in the commission, HCAHPS and HEDIS scores are really patient satisfaction scores. They really are not outcomes data, and again, outcomes is important to understand as the numerator over cost to equal quality. So I still have a concern about our inability to really define quality and as it relates to outcomes.
So for clarity, Dr. Barron, just because it's a little confusing to me, I think that you're okay with keeping it in, but knowing that we need to still work out the detail of this, which is what I've highlighted. So unless you are proposing to pull it out, I'm just going to keep it in and not highlight it green.
I would keep it out. I'm not comfortable with that one as with the information that we've been presented so far. I'm just not comfortable that we can really adhere to that. So although I think it's a laudable goal, That's what I'm talking about.
So,
However,
okay, great. So you want to remove this one, correct?
Yeah,
Is what
yeah.
you're saying.
Although I do think it's something that we should work on, in the future as we learn a little bit more as a commission about how to grade health quality and outcomes, health outcomes. And I'm happy to be part of that learning process. Consolidation. I think I mentioned previously that I think that there's public record on those kinds of things. Somebody mentioned that maybe we could make, I think it was Commissioner Shaner said earlier after I made my comments that we could, limit that to certain sizes. I think that's exactly what the Attorney General looks at is that there's a threshold by which if a large merger acquisition is going on, the AG's office gets involved. And if this commission wants to be apprised of those, I guess I don't have a problem with that. I just don't know whether I would make it part of a BDR that requires it in addition to those things meeting the threshold of the AG's office requiring reports. So I guess I would say for consolidation, I would, at this point in time, I would need to flesh that a little bit more. And I would say personally remove, but again, I recognize what Commissioner Bond was saying in that it can affect healthcare markets and costs and things like that. And it's something that we should look at, but I think we need to know a little bit more about what we can learn from the AG's office as a commission.
So are you proposing that we need to learn more from the AG's office and just capturing the intent right now that we want to look into that so that we would then keep it here, just knowing that we would still need to look into that?
No, I thought.
I'm trying to make it so so everybody, it's an easy conversation because it's kind of going a little bit back and forth for me. So I'm just seeking clarity.
Right. I guess I would say my personal feeling is I would remove it until we can learn more from the AG's office about what information would be available to us from their office as a commission. And maybe that would flesh out that there's a lot of things not meeting the threshold that are going on in our medical community that we do need to be apprised of, but I just don't know that we know that yet. I think that there's a gestalt maybe amongst some of us that we need to know more, but we just don't know because we haven't been apprised of what meets the threshold and what's concerning. So my personal feeling, and again, I'm just one of 10 people, is I would remove for right now until we know more information.
However, it might be useful to put the removes in red and the keeps in green as per Mason's suggestion. Maybe that makes it easier for us to really see it.
I think, well, the red is hard to see, Dr. Slonim, and I think it's just, we're going to keep everything that isn't selected as removed, right? Because this is our foundation. So I think that if I do red, let me just show you, it's pretty hard to see, at least on my screen.
And I'm sorry to interrupt, Dr. Barron. You've said twice that you want to wait until we know more, but my whole point has been like, how do we know more if we don't gather anything? So could you clarify on both of those, how we get those back out of the remove column? Because I'm just saying we don't have it, so we're never going to get it is where I'm getting frustrated.
Yeah, no, I understand. So with regard to the healthcare quality sentence, I think the commission needs to learn how healthcare quality is measured, what metrics are currently available within our state for healthcare quality, both from the provider standpoint as well as from the institution and hospital standpoint, and then what makes those things discoverable or out in the open to us as a commission, as opposed to what seemingly happens now, which is that there's all this wonderful data, but nobody ever gets to see it. So I think we need to just learn a little bit more about that as a commission in order to decide where to go. And I know that there's people that can make presentations to us about what data is collected, where the repository is, and how we have access to it. I just don't know, above and beyond that information, I just don't know what else we're going to be able to find. And then with regard to your question, the consolidation piece, if we had a presentation from the AG's office about things that are on public record that they can share with us as to what they've looked into in terms of mergers in, let's say, the last 2 or 3 years or something like that, and if nothing seems to be meeting their threshold, then maybe we need to move forward with our own inquisition about those types of things. But I guess I'd like to know a little bit more, be educated a little bit more from the AG's office about what meets their threshold for investigation and so forth. So those are the things that that would be actionable items, I guess, on those two things for me.
Can I pause for a moment? So if there is, just to go back to Commissioner Bond's point, if does it make sense? Do you want it removed, or should we put something instead? You either have one where you believe to just remove it from the intent of this legislation, or I could change it to further review, right? So that way you're still capturing the idea that you value this item. You just need more review.
Well, we're trying to author a BDR, right, which is ultimately something that we're trying to put into state statute and into law, and I feel uncomfortable agreeing to put something in our language of our BDR that I feel like I just don't know enough information about, and that seems very, very broad. That I'm not sure it's a good idea to try and promote a law without having a little bit more information about how healthcare quality is measured and what things are available to us. It just seems like putting the cart before the horse to me. So that's why I recommended remove on that. And with consolidation, again, I think we understand what we mean by consolidation. We understand that the potential importance for that, but I'm concerned that this commission hasn't been apprised of what information is available and examples of things that have seemingly affected our healthcare market and cost that have slid under the table that we never got to see. So I think that the AG's office could apprise this commission about that before we put it into a statute.
Yeah, and I'll
Thanks,
remind everybody that there's a second process to this, and this is going to have to go through the legislature and 63 others who are going to be asking, no doubt, extensive questions. And so, and I'm sure what you're raising now will also be raised with other legislators. So this isn't, this is the first process. I just want to make sure, I know everybody knows that. I just wanted to make sure I restated that.
Right. I just wouldn't want to be in the position of having to give public testimony in support of the bill draft to the legislative subcommittee that would hear this without having full information and being able to answer the questions about, well, why did you think that you needed transaction reporting to the PPC and so forth, and have 3 legislators asking me about that and grilling me, and then I can't adequately answer because I feel like I don't have all the information, and I might shrug my shoulders and go, well, maybe I don't know why I need all of that information because I haven't really talked to the AG's office and they haven't really told the commission what kinds of things they're discovering and what kinds of things they're not.
Well, I'm sorry to interrupt. We're going to run out of time though, Chairman Khan.
Yes, I'm just figuring out we need to move on to the next people rather than a lot of cross conversation.
Yeah. All right. Well, let me just summarize, kind of globally here and say that my personal feeling is I'm in favor of moving forward with the portion that asks for an all claims payer database, and that most of the other language I think is something that I personally feel more comfortable tabling for more debate and discussion and evidence-based pushing forward. I feel like there's consensus in the group on the all payer claims database, and that most of the rest of it that we still haven't driven consensus.
So I think let's move on,
comment.
Howard, if you don't mind, because we have a lot of commissioners to chime in.
Yeah, no, so that's fine. I'm finished.
So let's move on with the next commissioner online.
Okay, Dr. Packham.
I will keep my remarks short. I agree with Howard that we should limit it to the all-payer claims database. I think it provides a foundation for some of the other items in the draft that we're looking at. I am in agreement with most of the things in that draft, but I think they're aspirational, and would just want to point out that I'd like to see a BDR go forward that's not going to, that will be clean and that won't have poison pills that will kill it at the end of the day. And so I think keeping it short and sweet to the all-payer claims database is what I would recommend.
All right, so the next person in our system.
Dr. Slonim.
Thank you. I think I would agree with what's been said. The only provision I would be supportive of would be the all players claim database. And I would, am happy to do this if you want to go down the list. I would take out the transparency measures, the inventory. I would remove the quality piece. I would remove claims, costs, confidentiality, and the hospital price transparency and the expanded authority, just so that we're clear.
All right. The next
Mason?
commissioner.
Sure. Mason?
I agree with everything that's been said so far. I think the all payers database, I think definitely we can refine that, work on that. I think we agree on it. I do like the quality portion, but I think as a committee, we could pull something together that takes all those industries and metrics into consideration and maybe create our own dashboard without putting that into regulation. I think that's a work product this commission should be able to produce and bringing all those pieces of data together. So I've been supportive of with what's said so far. So no further comments, Mr. Chair.
Thank you. Who's our next commissioner online?
Sure. Mr. Shaner?
Thank you, Mr. Chair. I think I want to echo some of the things that Commissioner Bond said that are impacting this community on a regular basis today. That while the AG or other offices might be collecting or looking at certain information as far as private equity venture capital funding impacting the healthcare market, nothing's happening about it other than it's raising costs in this market tremendously. And that's whether they be on professional providers or facility-based providers. More and more of that money's coming into this market, and it's impacting every single person in this market. And what we don't have, in my opinion, is an aggregator of that information. And I think that's where Commissioner Bond might be trying to go with this when we look at what some of our future responsibilities might be. No single citizen out there is looking to go collect information from the AG, DHHS, or any other state entity and then aggregate it themselves to try to get a picture of what's happening in the healthcare landscape. And that's what we're trying to do here, is take all these pieces and pull them together. So shining a light on that consolidation is something that I think will protect patients on a go-forward basis within our state. And I don't want us to just sit here and think, the AG's got it. With all due respect to the deputy AG on this phone, who I think is a great person, I haven't seen anything that's come out that says this is what's happening with respect to private equity in this market, and it's impacting us all, whether we know it or not. And I do think that we have to think about what we should be in the future. And I think I'm using the word aggregator as a one-stop shop, more or less, for anybody who wants to know what's going on with healthcare to be able to come and get some information. And I don't want us to dismiss that and focus solely on one piece of this bill, because I think the others are very important as well. Maybe that's a long-winded way of me saying I like the various pieces of this bill as opposed to just the all-payer claims database. I think they are all important. And I hate, we have 9 minutes left according to our time frame here. I don't want us to feel rushed to put something together in 9 minutes, because I think that would be even a larger disservice to what we were put together to do in the first place. Thank you.
All right, thank you. Who was our next commissioner online? Is the next commissioner online?
Sarah, you're muted.
Yeah, sorry, I was calling on you. Thanks.
Were you calling on me?
Yes.
Oh, thank you. I'll be short as well. I would support the all payer claims database provisions. I would ask that we also include the 2 first paragraphs of the transparency measure. I think those go hand in hand with the all payer claims database. And then Sarah, if you could scroll down, I would also like to see or have no issues with the seek administrative penalties for failure to support required report or required information as part of the all payers claims database, to make sure that, you know, those that are participating in that, make sure that we do provide the information. I would go down, I would add the additional data related to pharmaceutical claims as part of the all payers claims database. That information is important. So take that whole section, I would add that into that bill. And then I would also do the data related to patient healthcare costs. I do think that's important as part of the all payer claims database to give us a holistic picture as to how that's impacting patients. And then for confidentiality, I would add, we would want to include a confidentiality provision. And, you know, to Commissioner Bond's point, I agree. We have no problem with reporting at an aggregate level a summary of the output of what comes out of that database. I think we're just concerned about making sure that the information that goes into the database, that there is confidentiality around certain types of information that go into that database and that's collected, to make sure proprietary data is protected from public disclosure. So we can work on that language, but we would want some kind of confidentiality provision included in an all payer claims database. And I think that is, if you go down to the bottom, keep going. And then regulations, I think there needs to be some kind of provisions in there when you go to implement the all payer claims database, that there be some allowance for a state aid entity to be able to draft regulations to implement.
Sure, and just for clarification on this regulation piece, this is actually at the request of Director Whitley from our last meeting, to make sure that he has that the authority to develop those regulations. And so this is actually the language that he requested and spoke to you all about at our last meeting.
Okay, thank you.
All right, so I think we have, who's the next one online? So
Okay, we've got Jessica, and then we have Yarleni after Jessica.
I really liked all of Flo's comments on the all payers claims database and the things to be included on that. That felt very well vetted, and I also appreciate including the regulations for the division. In terms, I also really like this idea of the inventory. I think that makes sense, that we're building a ground to stand on for the commission. In terms of the report, I hear Commissioner Barron's concerns about, what is quality. I think that's a really good example of patient satisfaction rates when you're trying to prescribe opioids. What does that look like? And I think that the inventory in the all payer claims database could start to sort some of that stuff out. I also really like what he was saying, that we got a national overview on mergers and consolidation. And I don't know if we ever heard from the state on where we're at. And it would be great to have the AG's office give a presentation on that. I know no one has enjoyed what I've said about the BDRs, but tomorrow is a bit of a false deadline in the fact that we can put in as much or as little data as we want for those 3. So, I mean, if everyone feels comfortable on the all payer claims database, that seems like something that could really be really fleshed out in that second BDR. And I wonder if that third BDR, if there is more time or room for more education discussion and getting some more specifics on that. Because yes, the legislators are going to see this, but they'll go, oh, the Patient Protection Commission approved this. And I feel like there's still not enough specificity to not feel like I'm rubber stamping something that I don't understand. So I wonder if there's a middle path here.
Okay, I think we're going to move on. Yarleni?
Okay, so I agree with Commissioner Flo and Commissioner Schoner. I think I want the whole BDR, everything that's in there. It needs to be passed. I like it all to be included.
All right, so Commissioner Bond?
Thank you. I'm trying to, I can't process this stuff fast enough with all the commissioners, so give me a second. I appreciate it. I think that trying to break what Commissioner Flocon said about breaking this into separate BDRs, I would rather preserve what we can in this BDR. And I thought that Sarah was thoughtful about making sure she checked with LCB all the way along to make sure that everything was in scope and that we didn't use BDRs for things we don't need to use BDRs for. So I'd like to push back a little bit and get what we can into this BDR. And then if there's things that we can't, we just really can't, then let's explore how to use the third BDR. So I appreciate Commissioner Flood's and Commissioner Khan's thoughts about it, but I would rather use this BDR to the fullest extent we can. I think it will just make more sense. There's too many BDRs in session that don't make it through the pipeline, and you want to preserve your chances. So a lot of BDRs out there just weaken the chance of anything else happening, in my opinion. But I'd like to challenge Dr. Barron to help me figure out what he thinks would be an appropriate quality measure. I know you're saying HEDIS is all processed, but HEDIS includes immunization rates, it includes access, it includes a lot of things that are not just, did I get my opiates? And I'm not saying that I'm married to HEDIS, but I think we can find a national benchmark. And so rather than completely take out, we're not going to try to collect any quality, let's just see if there's anything out there nationally that that you are more amenable before we kill it off. So the BDR could say that we're finding out, this thing is about finding out the quality reporting every year. Maybe the first year the quality report will be, we don't have any quality data on this, and then we build it. But that's all this is saying, is we're going to do a report on quality, not we're going to mandate quality levels. We're not mandating things. So other than, I think the consolidation stuff is like new data that we're trying to collect. So I'm trying to be responsive to what I'm hearing as the concerns. And I think that there's a way to get something in a quality report every year to identify what we don't have without saying we're not going to even collect it. Consolidation, I'm happy to have the AG weigh in on what they get now, but I believe what we're going to find is there's a lot of things that aren't reported, and that is what Jamie King talked about, and that is why states legislate, to get transparency about data. He doesn't know what's coming in as private equity. That's not a merger, so he doesn't see it. The idea of what threshold is appropriate for more data to be provided or transparency, I'm fine with that too. So again, I'd like to push back and say, let's keep consolidation in the BDR, but let's, as Commissioner Flood is saying, use between now and November, when we need specific language, to figure out what else we would try to do to specify the bill, and LCB can be working on it in the meantime. We have that window, instead of lose the whole issue, do the research that we need to keep.
Commissioner Bond, can I have you pause for just one moment? Sorry, our chair is dialing, so if we could just take a quick moment to just pause. He needs to dial.
I need it anyway
back
to try
in.
to capture everything that you guys.
Okay, sorry.
Okay.
If you guys can all give me a moment, let me make sure our chair can join us. Okay, Chair Khan, are you there?
Can you hear me now?
Yes, I can hear you. You're back.
Okay, great. So I am on. So that's
Okay.
terrible.
No, no problem. So
Right.
we are actually on Commissioner Bond. I just asked her to pause for a moment. She's
Go ahead. All right.
Okay,
Sorry,
great.
I apologize. Technology.
That's okay. That's okay, Mr. Chair. I don't know what you did and didn't hear or where we are either. So,
So I'm here most of it till Sarah paused it. So until
Okay.
then I could hear, but then you guys couldn't hear me.
okay. Okay. So I was saying to Dr. Barron that HEDIS measures aren't just process measures. They're not just patient satisfaction measures. They are a lot of process measures. But I totally agree that outcome measures are better. So if we have a way to figure out what we can and cannot get, then the first year of the bill on providers could be, we need the providers to agree to this information. Or here's the 5 different ways providers are reporting something. We don't even have great transparency on immunization rates. You can get them, but you have to. So there's things that we could do in what Commissioner Shaner is calling an aggregator, which I kind of like that idea of how this bill would actually evolve into real data. But we need to start getting this together. And in my biggest concern is waiting another 3 years to do anything on these things. And I think if we have the authority to do it and we have a BDR asking us to collect this stuff, it's better than saying we're not going to ask for anything until we know exactly what we want, because that is how transparency works. It's iterative. You get what you can, you start with what you can, and then you build as you go and figure out what you don't have. We're never going to have a time when we know exactly what we want to collect, because if we did, we'd have it already probably. So pulling in what we do have and then figuring out from there what we don't have is going to be a process. And I just really would hope that this commission will get started. I don't know how to respond to Dr. Packham or Dr. Sloan, but they don't want to proceed beyond all payer claims database. I appreciate Commissioner Mason's support for trying to create some sort of dashboard, and I appreciate that there's several commissioners who seem to want to move forward on trying to consolidate some of these issues a little bit. With the chairman, Dr. Khan, I just disagree that the AG has, I'm not trying to compel us to take power away from the AG or match the AG's power, so I'd like to clarify that. I'm just asking the DHHS and or the Patient Protection Commission have the ability to track what's going on in the market and have the ability to understand how many doctors have now floated into consolidated practices, how many practices are being run by private equity outside of the state, how many ERs are run by private equity outside the state, and what is happening with who owns the physician practices in town, as well as the hospitals. I know a lot about the hospitals, it's my job, but we don't have a way of seeing anything systemically in what's going on in the healthcare industry. So I feel like nothing that we've got in this bill should be considered threatening. I totally understand people saying we don't know exactly what we're asking for. I get that, but I don't think that's a reason that we don't do anything. So I'd just like to add specificity to these issues instead of say, let's just drop it. And I disagree that a third bill should be used unless there's things in this bill we just really can't do, and there might be. And then I'm okay with that.
Okay. Thanks a lot, Bobette. So I understand your view on the information the AG and so perhaps DHHS should have some information on what's going on in the marketplace overall, rather than mandating people to do if they have available data on the providers, etc. on the side. Besides, like you said, the hospital information, all mergers and large organizations, that is public record what's happening. If you're concerned about the other areas of smaller areas that are merging or are being acquired, etc., if there's a way to keep track of what's going on at the DHHS level, perhaps that may be okay. I don't know what purpose it will serve in terms of patient access and quality of access, etc. but let's have everybody else chime in and see what we narrow down. We have really over time, unfortunately, so let's move on. Who else is left?
Chair, that concludes the first round. I do have some commissioners who have their hand raised, and I don't know how I can help organize your call. I've taken some notes, so everyone has a general. It's very difficult to change the language because there was a lot of deeper discussion that was going on. So I'll defer to you what you would like me to do. I'm happy to kind of take a summary recap of the notes that I've collected for the first round, or if you'd like, we can go into the second round or call on those who have their hands raised.
I think two things. In the interest of time, I'm really concerned. We have gone along already, a lot more to accomplish just on the second BDR. So two scenarios that I think perhaps will help us. If you can summarize whatever has been discussed, and then those who have raised their hand, if they're in agreement or disagreement with that summary, then perhaps we can start that way. So if you have summary of various discussion items, some in agreement, some not in agreement, etc. If you can highlight those, then the commissioners who had their hands up, they can chime in on those subjects so we can narrow this down a little bit. So I really need to conclude this BDR ASAP because we have a deadline to meet.
Sure. Okay. So the first thing I think that maybe, and bear with me, commissioners, I'm trying to do my best here to try to capture everybody. I think that it seems like by my count, I've got 2 commissioners who want only APCD, and I have the other commissioners wanting, it looks like the APCD plus other elements that could be captured in this. So perhaps we start with just the idea of only being an APCD. So if you want to take a poll of the commissioners at this point to just have that, or does that sound good? And then I guess we can go over the other portions.
Yeah, that sounds good. So if you the record read what's only in the APCD.
Mr. Chair, this is Tony Sullivan. Just a quick question. Maybe this would help us move forward. Given there was so much conversation, I know I've taken in all of the conversations that folks have had in our second round here. Maybe what we do, one suggestion might be that we could go paragraph by paragraph and do a roll call vote about what stays in, what stays out. Doing all payer and then all payer plus is really confusing because there's so much conversation that occurred at the individual paragraph level.
So Sarah, what do you have on that context?
Actually, maybe there is something, and I'm going to go back to what Commissioner Flood said, and there's some way for us to find a solution here, and that all of this is the details. Right now, I'm going to just go back to what she had indicated, and that this is the first step. There is an opportunity to provide more detail, more clarity once we get the language. We certainly don't need to have it all worked out at this stage by any means. And if that is where a lot of the commissioners are feeling that is happening, I'd like to remind you that this is really just the first step in requesting this draft. We will get it back from legal, have the ability to make some slight modifications before it's pre-filed in November. Legislative counsel, legal counsel has just said the more detail that we can provide to help them in their drafting is really the intent of the conversation and the action today. So perhaps maybe if we don't want to go down the different points and you save that until you get the language and start having those robust discussions, that is an option. And I think right now, is my screen being shared? Let me just share, hold on.
While you're sharing, if I could just say a couple of things. So I think you're right, Sarah. I mean, I think if it would be great to try to digest some of this stuff, get more information and education, and maybe we could send you, like requests on what that would look like. But I really worry about, I think as long as the motion is non-binding in whatever we move forward with. And then the other piece is I feel pretty railroaded, the whole time I've been like, oh yeah, that kind of sounds all right. I guess I'll put it in here. And now it's in. And then it's like, oh, well, you said that you were okay with this and now you're not, and so I'm concerned about taking the next step with these hazy issues. And then when the language is there, really still feeling like, well, you voted on this, so I guess I just wish that there was a little more flexibility in this.
I appreciate that. And I should pause for a moment too and just say, and then highlight what I meant to say. My intent is that I think Commissioner Bond said it really well earlier, is that she is coming to the table. She is putting forward some language. Some of you are. I think I've got like 4 of you that are really submitting some language, trying to figure it out. And I think what I'm asking is in between our meetings to continue to have that dialogue, to continue to take the next step and figuring out some of these details, and not necessarily just waiting until we either meet in person, unless that's your prerogative. If you'd like to meet in person because it's better for everyone to have this each time, then host more meetings in more frequency. But given our schedule, our time frame, we just need to be mindful of what is the most efficient path forward. And so having the dialogue in between is helpful.
So I just want to throw out though that efficiency,
I need to get this meeting back in a little bit more control.
Yep.
We are all over the place, unfortunately, all over again. So perhaps we need to go item by item and narrow things down so that because everybody has a chance to speak. So you need to narrow down, to Tony's point. We have several items on it. Let's opine on it, where we are, where the majority people said something, and let's go one by one item. So we have addressed everything and get some control to bring this meeting to an end in a reasonable time. We're already way past.
Okay, great. So then let's, how about what we'll do is we'll follow kind of what Dr. Sonam suggested, and we'll take it piece by piece. And if we
I think we need to go piece by piece, and please restrict your comments as much as possible, unless they are compelling, that would make a difference significantly in the language process. And I'll go by vote on each item to get it to an end, because we are going all over the place all over again with future possibilities, future language, future this and that. I need to wrap it up today, one way or the other, so that there's a final bill draft language from us. If it's to be tweaked down the road, we have that opportunity, we can certainly do it.
Thank you, Chair. So I've got a couple commissioners right now that have their hand raised. I'm gonna lower everybody's hand because we'll use that as a way for you to indicate if you're for this or against this language. And I think, okay. So
raise hand with respect to them. If as the item is going by, if their opinion was about that item, then certainly they can speak up.
Okay, great. So let's start with the legislative intent of this proposed bill draft. Is everybody in agreement with this paragraph? If you are in agreement with the overall legislative intent of this bill, please raise your hand.
And please put it on the screen so that everybody can see it.
I believe I have it on the screen for everybody. Yes, I think. Okay.
Okay.
And then, okay, all right. I'll wait. Okay, Chair Khan, we've got 6 members who have raised their hand and indicated that they are in agreement with this language. So that is already simple majority for that provision. Do you want to move forward?
Is this vote
yes, please.
Per open meeting law? I just want to make sure.
Yes, please do. And if we have already 6 who are in favor of that, then that's a simple majority.
Okay, so should I then tell everybody who is listed right here that, again, we're going to go back, everybody's in agreement, the intent of the proposed bill language here. Okay, there was somebody who just took their hand off. Okay, so I've got, does anybody else want to raise their hand now? Okay, great. I'm going to name off everybody who has raised their hand at this point. And so we've got Commissioner Flood, Yarleni Roa Dugan, Mr. Shaner, or Commissioner Shaner, Commissioner Bond, and okay, now, all right, I'm confusing. I just had a couple people lower or not lower. Let me just pause because it keeps going back and forth. I've got folks taking it off and not taking it off. Okay, now I've got Dr. Packham for it. Is everybody?
Okay, so we need absolute count ASAP, so we can move on, please.
I'm also there on that first paragraph.
You're good with the first paragraph,
Yeah.
Dr. Slonim? So, okay,
I think
Where's
some
Doc-
people are
where's
physically
Dr.
raising their
Khan's
hand.
photo?
Some
What?
people are physically raising their hand and some are doing
oh,
it.
okay, so, oh, got it. So guys, I cannot see if you're physically raising your hand because I cannot share my screen and see your hand. So maybe that's where the confusion is. So
Well,
if you
and
can,
we can't raise our hand while you're sharing your screen. It's hard on some devices.
oh no, okay, so,
Really?
then can we just do maybe a roll call vote? If maybe that's easier,
Yeah,
guys, because
please.
technology is not our friend.
Yeah.
So I'll
Yeah,
do a
please,
roll
let's
call
go
vote of
ahead with
everybody.
it, please.
Okay,
Yep.
I think that's better. All right, guys, we're figuring this out. Thanks. All right, let me start. So again, I'm going to highlight here on my screen. This is the provision that we're all seeking approval on. So the legislative intent of this proposed bill, Dr. Barron.
I'm a yes.
Okay, Dr. Packham,
Yes.
Dr. Slonim,
Yes.
Mason,
Yes.
Bobette,
Yes.
Sean,
Yes.
Flo,
Not voting.
Not voting?
That's
Mhm.
abstention.
Yes, an abstention.
okay.
Okay,
Do we need to have let me ask our DAG. Our DAG, is that okay? Is that permissible without a disclosure?
yeah,
Okay, great. Jessica?
I'm also voting for it.
Okay, sorry. All right. Jessica?
Yes.
Yarleni?
Yes.
Okay, great. We are all in agreement with this program. So this provision. So if we take, this is good. All right. Give me a moment, guys. I'm going to highlight everything, I think, in green now. I know red looks bad, but maybe I'll do red for anything that we omit. So let me just go forward with green is everything that we've agreed on. Okay, on the transparency measures. Let's take the first paragraph here. Okay. So this provision, are we in agreement? I'll go down roll call. Dr. Barron?
So are you just asking about that highlighted paragraph that you?
Yes, just this gray one.
I'm
So
in favor of that paragraph.
Could
yes.
you please read that for me? My screen
Oh,
is off.
sure.
but I'm
Sure, and I should do it. Okay, so transparency measures, this detailed transparency measures must include all aspects of healthcare ecosystem, including but not limited to providers, insurers, hospitals, PBMs, pharmaceuticals, labor unions, and the state.
okay. Got it.
Okay,
Let's go proceed with our vote.
all right, Dr. Barron?
I'm in favor of that paragraph.
Okay, Dr. Packham?
Yes.
Dr. Slonim?
Yes.
Mason?
That's a yes.
Bobette?
Yes.
Sean?
Yes.
Flo?
Yes.
Jessica?
Yes.
Yarleni?
Yes.
Okay, great. And now we're gonna go into this second item, and it is require an inventory of the currently reported health data in Nevada that can be used to analyze trends in cost, prices, consolidation, and patient access to care.
Sarah,
I'll
Chairman, what are we going to do about the fact that Commissioner Bohannon's not here today?
Well, we have a forum.
Okay. So,
So
but then
as
now,
long
but
as
now
we
we're
have
voting with like simple majorities.
Yeah, and it's going by simple majority, and we have a quorum.
Okay, I'd like to go back and talk about this depending on how it goes, because it's if it's of a one vote, I think we have some issues. Okay, thank you.
All right.
Okay, so we're gonna start, and again, it's this paragraph, require an inventory of the currently reported health data in Nevada that can be used to analyze trends in cost, prices, consolidation, and patient access to care. We'll start with Dr. Barron.
So if I'm understanding this correctly, we're just asking for what is currently available. We're not asking for mandatory reporting from any particular agency in this paragraph.
So the details can be worked out on this. We're just requesting that as LCB is drafting this legislation, that they also include this intent. And so how they determine that is going to be based on the language we get, in which you will all have an opportunity to discuss and review.
But it does
So I
say
have a
currently
comment. I
reported.
think
It does say currently
I think it's
reported.
important what Dr. Barron, sorry, I'm overlapping your conversation, but what Dr. Barron, I think is asking is to specify whether the data that is currently available or beyond that, currently already available through various systems.
Sorry.
And I think that can be narrowed down. The LCB doesn't have to tell us what is what. To me, that's pretty straightforward, unless somebody has a different view.
Yeah, it does say currently. Sorry, there you go. That's
Okay.
what- yes, it does say currently. Got it. Sorry, Dr. Barron.
So I'm fine with that paragraph then.
Okay, great. Dr. Packham,
Yes.
Dr. Slonim,
Yes.
Mason,
Yes.
Bobette,
Yes.
Sean,
Yes.
Flo,
Yes.
Jessica,
Yes.
Lenny.
Yes.
Okay,
Dr. Khan, I'm a yes.
great. Thank you. All right, now we are going to this. All right, so this paragraph here, require a report each year summarizing healthcare quality in Nevada for presentation to the governor, legislature, and PPC. Okay, I'll start with Dr. Barron.
And I think it needs to be fleshed out. I can't support this as it's currently written.
Okay, Dr. Packham,
No.
Dr. Slonim,
No.
Mason,
Actually, yes on this one.
okay, Bobette,
Yes.
Sean,
Yes.
Flo,
Yes.
Jessica,
Yes. Could we have a caveat about adding specifics, like specifically what the indicators would be?
I think that that's going to be discussed, so that you're just agreeing to include this in the draft at this point. And again, you'll review the language and the details when we get that back, and you guys can have a further discussion about that.
Okay.
Okay. So Jessica.
Yes.
Okay. Lenny.
Yes.
Okay. And Dr. Khan, you're the last.
Yes. Just I need some clarity down the road, and we understand that will be an opportunity to clarify what specifics on this healthcare quality data.
You got it. Okay. All right. Let's move on to this paragraph, which is consolidation. So let me just read this. Sorry. Okay, consolidation require pre-transaction reporting to the state of Nevada affiliations, mergers, joint ventures, or acquisitions between a healthcare system, a health plan, private equity group, or hedge fund, and a health plan, healthcare facility, or provider. I will start again with Dr. Barron.
No.
Okay, Dr. Packham,
No.
Dr. Slonim,
No.
Mason,
No.
Bobette,
Yes.
Sean,
Yes.
Flo,
No.
Jessica.
No.
Did you say no?
Yeah, no.
Lenny.
Yes.
Okay. Okay, and Chair Khan.
Is this Flo Khan or me?
It's on you.
No.
Okay. Okay, so we are agreeing to remove this one. Okay, now moving on to the next paragraph. Report by facility the use of emergency relief funds made in response to the COVID-19 pandemic provided by the federal and state governments. So I'll open it back up to Dr. Barron.
No.
Okay, Dr. Packham,
No.
Dr. Slonim,
No.
Mason,
No, I think the governor's task force will do that. That's why I'm voting no.
Okay. Bobette?
Yes.
Sean?
No.
Flo?
No.
Jessica?
No.
Yarleni?
Yes.
Okay, and then Dr. Khan?
No.
Okay, all right. We've got an agreement to take this one out too. Okay, and this one is seek administrative penalties for failure to submit required reports. I want to remind the commission that this is also in conversation with DHHS from our last meeting, that this kind of falls in line with what Commissioner Khan had indicated too with other reporting legislation and laws that we have now. So that's what this piece is for.
Isn't there already language in the NRS about that, Sarah?
Yeah, I think, and so I think when I spoke to Director Whitley, it was really just, I don't think it's necessary in here. It's just to make sure that they capture it, that they capture that language.
I think there's been problems in the past when they haven't had it in the statute.
Yeah, and if it gives you guys comfort that you don't want to move it, I can actually just put this down as just an FYI for LCB if we want to do that, or I can keep it here. I'm not sure if it matters, or let's just go down the roll call. So Dr. Barron?
I would say no, just because it's unnecessary.
Okay, Dr. Packham?
No.
Dr. Slonim?
No.
Mason?
No.
Bobette?
Yes.
Sean?
This one matters.
No, it's redundant.
Okay, Flo?
Yes.
Yeah. Okay, so is this, okay, well, that's fine. Jessica?
Yes.
Okay, Yarleni?
Yes.
Okay, and then Dr. Khan?
No.
Okay, 1, 2. I think so. Should we just remove, that's fine. Let's move this on to, and again, I'm going to remind you that I think we.
Sorry, I was off. I want to change mine to no. Sorry.
Okay. Additional data related to pharmaceutical claims. So I'm going to highlight all of this. Okay, and then I will start with Dr. Barron.
Can I ask a question before I give you my vote? And it's of Commissioner Khan, because I remember her saying something about which language she liked better, or thought was more suited, and I just wanted to hear that from her again.
I believe she was referring to the confidentiality portion on that one, Dr.
Okay,
Barron?
That is correct.
Okay, just the confidentiality, portion then. Okay, so then I'm a yes for this.
Okay. Dr. Packham?
Yes.
Dr. Slonim?
Yes.
Mason?
That's yes.
Bobette?
Yes.
Sean?
Yes.
Flo?
Yes.
Jessica?
Yes.
Yarleni?
Yes.
Okay, and then Chair Khan?
Yeah.
Okay, now we're going to move on to data related to patient healthcare costs. Okay, this is
Could you read it for me, please?
data related to patient healthcare costs. The average patient expenditure on insurance premiums and cost sharing, including the average patient deductible, co-insurance, and co-payment amounts.
All right, let's proceed
Okay.
with the vote.
Dr. Barron?
Yes.
Dr. Packham?
Yes.
Dr. Slonim?
Yes.
Mason?
Yes.
Bobette?
Yes.
Sean?
Yes.
Flo?
Yes.
Jessica?
Yes.
Yarleni?
Yes.
And then Chair Khan?
Yes.
Okay, great. Now moving on to the confidentiality portion. We've got, this is the original language that was proposed by Commissioner Khan, and then this is alternative language that I don't believe we've
Could
had
you
a discussion.
the language, please?
So should we start with the first one? Is that how we want to do that?
The original language and the change.
I think this is going to be hard to do because
I think so too.
I think this one needs some work.
I agree.
We could also move to just remove this entirely and then have that in as as an addition to when you guys get language. So that way, if there's two conflicting languages, maybe the vote would be to just take this out in its entirety.
That's a good suggestion. I think the top language is a little bit tighter than the bottom one, but I'm happy to take it out and move on.
Okay, so what
Yeah,
I'm gonna be, okay, so the vote right now is just to remove both of these in its entirety for discussion later. Dr. Barron?
I would agree with that.
Okay, Dr. Packham?
Agree.
Dr. Slonim?
Agree.
Mason?
Agree as well.
Bobette?
I guess so. Yes.
Sean? Okay.
Yes, agree.
Flo?
Agree.
Jessica?
Yes.
Yarleni?
Yes.
And then Chair Khan.
Yes.
Okay. Now we're going on to hospital price transparency. This language right here is specifically to codify the CMS hospital price transparency final rule into Nevada law. This was at the request or highlight of Commissioner Barbara Richardson. Okay.
So this is stating that whatever is in the federal government thing needs to be codified in the state process. And just for recollection of mine, there was discussion that the CMS element is still up, not defined or clarified, etc., and it's an appeal, etc., etc. We don't know which way it's going. Correct?
Yeah, I think that's okay. And Commissioner Richardson is on the line. She's the one that kind of brought this to the commission's attention. And I believe the final ruling passed late last year or in 2019. There was a federal court case and there's a process there, but this is a final ruling. And that's what she brought to our attention.
So the court case has been addressed?
The first court case, the hospitals lost in court. The hospital association is now appealing that.
So it is still on appeal though?
Yes.
So it's not a final word yet on federal law?
Correct.
The law is final.
No, Chair Khan, the law is final.
Okay. But the final rule has been delayed. The implementation of the rule has been delayed pending appeal. There's a difference. It's not like it's going through.
Yeah, that was my understanding, that as long as things are on appeal, they are not final because they may win or lose an appeal. So is that correct, that it is still on appeal? So right now it's there, but it's on appeal and pending appeal, it doesn't go forward.
I don't know enough about this. I just know that it did get challenged and then the ruling held up. And I believe there's another appeal like Dr. Slonim mentioned for a delayed start time. They have not yet ruled on that. And that is, it's not about the ruling that is in appeal. It's really just the start date. That's my understanding.
That's not true. That's not true. The ruling is under appeal. Not just the start date. The start date was, there was a motion to delay implementation pending appeal. That's different than what you said.
Okay.
And that's been brought up by both the American Hospital Association as well as the Federation of American Hospitals, and is under review. So I don't know how we can move forward when we've got something at the federal level that is currently being appealed. It's not implemented yet.
Right, and the way I understand the court processes go, not to belabor the point, I mean, to codify something in our state law and something changes federally, then we are starting all over again. The legislature does meet X number of years to revisit that, and we have already codified it and codified something that may or may not be negated at the federal level.
Yeah, and I think what I could suggest too is I think that the original ruling, and if somebody else knows this, the start date was intended to be January 2021. So, you know, this is, if you guys want to include this to codify in 2021, but I mean, this legislature is not going to meet until 2021. So I think it's just, they have to rule soon. So whether you want to include it now or not is at your discretion.
I would take this whole section out, given that it's under review and in the courts at the federal level. Why would we do something that we have to undo when we get there? It doesn't make sense.
So let's take a vote on to eliminate the whole thing or not.
Can we just, wait, can we just say that we would just add the language pending federal approval?
No. We don't know what federal approval, no, because we don't know what federal approval is going to be and how that cascades to the state level. We have to have discussion on it.
Yep.
Oh, God.
There's got to be process. If we don't have process, we don't have anything.
Well, there is a final
and I agree
rule.
on this. So let's move on, take a vote, please, so that we can move on to the other.
Okay, Dr. Barron?
And just so we're clear, we're voting on this whole section on hospital price transparency?
No, just the first line.
Just the first line.
But it's all under, isn't it all of it under review at the federal level? All of those paragraphs in that section?
No, they're not.
Yeah, they are.
A field existing require hospitals to report parent company each year to what we're already getting in the state quality reports. That's not a federal issue. Neither is the report by DHHS price trends.
Okay, my mistake.
Okay, so this is what we are voting on right now, is to specifically codify CMS's hospital price transparency final rule into Nevada law. Dr. Barron?
So I thought we were saying eliminate it or not to eliminate it.
Right, so at this point, it's either, if he votes for it, then we're going to keep it. If he votes against it, then we're moving to then remove it.
Excuse me, this is Mason. Can I make one suggestion before we vote on this? Because it is unclear and it could be years. Sorry, the Thunderbird just flew over, which is pretty cool. The price transparency final rule, can we just maybe take out the word final rule and adopt all CMS price transparency regulations? And then whatever goes forward, whatever goes backwards, I just have a problem voting for something that's in an appeal process. It's just a suggestion because I think it's going to be a no vote for most of the group because it's pending. So I just think it's safer to just add, adopt all CMS price transparency measures and regulations, and then you never have to go backwards or forwards to adjust this. Just a thought, because I think we can all agree that part of our signing up with CMS is we're going to comply with all rules and regulations for assignment of benefits. Just a thought.
So I think, Mason, I think that personally, at least, I think that's a good sort of in the middle of the thing that CMS price transparency regulations, whatever they may end up being eventually.
Yeah, and I don't want to, I think, Bob, that may achieves the spirit of what you're trying to attend.
Yeah, I think that's helpful.
Okay, so then let's vote on specifically codifying CMS price transparency measures and regulations into Nevada law, and we omitted the final ruling language. So this is what we have, and I'll start with Dr. Barron.
Could I have a clarify? I just need to clarify that really quick. What would that do?
Yeah, right. So we're putting something in place that tells us to follow the law.
Yeah. That doesn't make any sense.
Follow regulation and the law. That's foundational to,
Agree. It doesn't make sense.
Good point. That takes us back to the original discussion. I think Tony brought it up to perhaps eliminate this for right now, and then move forward till this all dust clears, and rather than go back and forth and back and forth.
I don't, Dr. Khan, I don't want to eliminate this. I'd like to see a vote on this. I'd like to see who votes against hospital transparency on the record.
No, which is fine. We are talking about the transparency codified in accordance with CMS, which is in limbo.
But so Bobette, can you explain why? I mean, like, I guess I'm very concerned about having to vote on something on concept when it doesn't do anything. So like that, you know,
Well,
like
it would add CMS.
Please, one person,
would add-
one person at a please.
I think what this would do, this isn't even my issue, so maybe Director Richardson should be weighing in on this, but I'm just very pro-transparency, right? So I think what they did last legislature on a lot of issues was codify the ACA, afraid that the federal ACA might be at risk or change. And so they wanted in state statute if federal law changes. On this, to Dr. Sloan's point, he's not sure that this is finished and it may change again. I think that we would be able to create, without any additional legislation, some sort of state link to what's ever going on federally to capture the transparency information. I realize if it gets knocked down in the courts that we wouldn't implement, but I don't see any harm in codifying in Nevada a way to link the federal stuff to the state. I don't see any harm in this.
But if you're a Medicare or Medicaid provider, you don't have any choice, do you?
Right.
Yeah, that's
but we won't have any state linkage to the federal law unless we create it. That's what always happens. There's some federal law gets created and we don't have any real access, transparency to it in Nevada.
No, but we're all obligated to follow the conditions of participation by CMS.
Yeah, I understand. I don't think you're hearing what I'm saying, Dr. Sloan.
Can I ask Bobette a question? And we've you know, the elite medicals of the world, and there's been some rules to require hospitals to participate in CMS, which I think was a great move for patient protection. I just curious, the way that this reads, say if I'm a physician that doesn't accept Medicare or Medicaid, does it force me to comply with those rules even though I'm not a CMS participant? The way it reads now, and maybe that's a question for our DAG.
Yeah.
I'm just curious to clarify that, to make sure that, you know, a concierge doctor that doesn't accept Medicare or Medicaid, would this apply to them to, because now it's Nevada law, even though that they don't participate? I'm just curious for clarification.
Well, I don't think CMS does price transparency for concierge physicians. This is about the hospitals. Should we add the hospital back in there, the hospital name in there?
Yeah, the way I read it though is take CMS laws and apply them to Nevada. So I'm just curious if I don't comply with CMS, now am I forced to do a Nevada law? And maybe that's for our DAG. I just want to think about that before we, I think overall 99% of the population this covers, but there may be some entities out there that do not accept Medicare.
Sure. Attorney Ott, are you on the line? Can you weigh in?
Hello, is he online?
Yep, there he is.
Sorry, Sarah. I had
okay.
an emergency pop up. Can I come back in about 5 minutes?
Yes, how about we just move forward, guys, and let's wait until our dad can come back on, and then we'll pause this portion of it.
Yeah,
Okay with everybody?
I'd just like to comment on what Commissioner Van Helling just said. If there 99% of the hospitals are complying with the federal law and there's one hospital that doesn't have to because they don't accept Medicare, wouldn't you want them to?
Yes, and so I think, I don't know if we need to wait for the DAG. I could vote on this, you know, but absolutely, I would. And I'm just curious of how broad the scope is for this entity. Say if a private home health company doesn't accept Medicare or Medicaid, which I'm sure there is some out there. We know that there's cash business out there. Do they have to participate in the price transparency rules that we're kind of establishing? Is just my thought process. I want to make sure it's all inclusive.
So basically, if 99% of the major institutions, organizations, and the physicians, or whatever it is, 95%, et cetera, are already complying, being a participant in CMS, should we be including as broad reinforcement for the 95 or 99% already participating to include them also in duplicating with the state process? Or just confine it to those who do not participate in the CMS program, that they should be reporting perhaps, rather than duplicating the CMS reporting already being done by those who are participants?
I don't think that we're making them report again, Dr. Khan. I think we're just making this report be available in Nevada. Really just, is Director Richardson on the phone? Maybe she has something to say about it.
Director Richardson, are you there?
Has he left?
There she
No, I
is.
didn't leave. Sorry. Yeah, I
Okay.
just had to unmute the other machine too at the same time. Okay, so the biggest issue with this has to do with the fact that CMS requires reporting, but CMS very rarely ever supplies that information to the states.
Right.
So if you want to know what's going on in the state, you tend to have to get your own information. Otherwise, you may, if it's public, you'll hear from CMS maybe a year or so after the data is gathered. And if you ask for it in the state, then you'll get it at the same time it's sent to CMS.
That's helpful.
Okay.
So it is basically available to the state when the CMS has it available for everybody else.
No, she's saying it's not unless we codify it.
Right.
We have trouble getting it.
Why are we having trouble getting it when it's releasing it to the media?
Because CMS doesn't do that always. They really don't.
No, they really don't. And sometimes they will take up to a year to release the information, and it's all in the aggregate, so you may not know exactly what's going on in your own state.
To my knowledge, it has been, if you put in the request, they would give it to you. And certainly the state can request that if we want to codify something, that the state on request from CMS can obtain this information. But that still doesn't force them to give it to you earlier.
Well, I think this proposed language addresses what we're trying to get to.
And you will
So
have an
what-
opportunity to look at this from LCB once they've concluded the drafting of this. And so you'll still have an opportunity to discuss this further.
Right, I really would like to move forward on this one to see whether the majority wants to codify anything that the CMS was already doing into a state phenomenon while it's still being contested, et cetera, at this point, one way or the other.
So can we take a
lot of
vote?
this seems like, I just want to throw it out. It seems like there needs further deliberation. And I guess my concern is the next meeting, when we have all this language, it's going to be just like this, where we haven't kind of sorted out the concerns, the education, et cetera, in meetings like this. It's one thing to do one-on-one, but this is the productive place where we're all together. So I guess I would really hope that we could have, weekly meetings every other week, whatever, and not just kind of wait a month until we get the language and then have another one of these meetings where we're all stressed and we don't know what we're voting on, even with the language.
To that effect, that's why I would really like to narrow things down as much as we can. And I think it's not feasible for every commissioner to make themselves available because they have a life separate from commission meetings. So a weekly meeting may just be too much, and I really believe so. And I personally cannot do it either every week.
No,
I'm sure
I
a whole lot
agree.
of other things going on.
Like
let's
every
narrow
other
this
week.
discussion. Yeah, so let's narrow this discussion as much as we possibly can, since we have already sat here a lot longer than we did. And still, if we keep deferring to future meetings, we'll have a problem. We'll spend another 3 hours at the next meeting. So I'd really like to narrow things down as much as we possibly can. If there's some tweaking to be done, that's fine. But if you're going to rehash this whole discussion at our next meeting, whether in 2 weeks or 3, we'll be debating forever. And personally, I have a real problem.
A terrible spot. I feel like everyone has a million questions on this. We don't even know what we're voting on, but we don't want to vote against hospital transparency, right? I mean, it's just like, what are we doing here?
So just for
This
clarity,
is a federal law that's already been passed. It's not like they went out and built a crazy spaceship. It's again, transparency. It's reporting data. We're acting like we're creating some crazy world. It's data. It's existing data.
Good point.
How many people on the call have actually read the CMS final rule? I know I haven't, and I'm being asked to vote on it.
So I think we
Yeah,
changed it based on Mason's suggestion, right? Is the commission ready to vote on this, where we've changed it to specifically codify CMS hospital price transparency measures and regulations into Nevada law? So that's not an indication of the final ruling language. It's about whatever is passed finally. Are we ready to vote on this portion, Chair?
Please.
So specifically, when we are saying codify CMS transparency measures into Nevada law, the CMS transparency measures are not finalized yet through court proceeding. So what are the transparent?
So when it does get finalized, I think the intent of this language is to capture those measures and regulations, as Commissioner Richardson indicated, as a way for us to access that data at the same time that it's reported. Because although we should, as a state, theoretically have access to it, it just is not happening in practice. And so I believe the intent of this is to also access that data that is being reported to CMS at the same time.
As long as we have something that we want to have access to that has already been accumulated by the Fed, and if we are not having it legally available, that's one thing. But to codify something in Nevada law that's unknown at this time is a separate thing. So we need to be very clear in the language we are using. What are we trying to codify without duplicating anything or doing something that is unpredictable at this time? So some can suggest a language to narrow down. I personally am opposed to a blanket, and it's not about being against transparency of the hospitals. I hate to duplicate things and mandate things at the state and duplicate something that the feds are already doing. The only question is, should state have access to that data? Yes, the state should have access to the data. Do we need to codify it into Nevada law to have access to the data? That I'm not so sure of.
Commissioner Richardson, is this language, would that capture the intent as we just discussed? If it's outlined like this, so it's not about codifying anything that isn't finished or finalized, but at least it allows us to kind of have that in process?
Yes, actually, LCB would be able to pick it up, and then you'd be able to look at that language specifically and see how it fits.
So let's narrow down the language today that LCB will be able to correct that, as long as we just have access to what is happening at CMS, and that we have access to that with or without having to codify it as a subject that can be discussed based on LCB's input.
Yeah, we would need to include this so that way LCB can draft something, and then we would discuss it after we receive their language.
So, Sarah, you want to summarize the language that you think that we are talking about?
Sure. And then again, this is to not capture the final ruling, but to capture the hospital price transparency measures and regulations that have been passed through federal law into state law to allow the state to access the data at the same time that it is reported to CMS.
Okay, so let's look at that language and let's take a vote.
Okay, I'll start with Dr. Barron.
Well, again, given that this would apply, since CMS federal law applies to all hospitals or all but a couple of small private equity fast tracks or ERs in Nevada, I like the idea of making those entities responsible to follow CMS guidelines once they get published. I'm just uncomfortable saying yes at this point because I have not read the final rule and so forth. And I know you took final rule out of the language, but ultimately that's what you're inferring to is whatever CMS comes up with. And until I see it, it's very hard for me to vote yes. So I'm a no for right now with that caveat.
Dr. Packham?
Are we going to have another opportunity to vote on this, though? This is really it. It's either in or out today, right?
Unless the bill gets modified in some form.
Yeah, we could totally modify this. Right? We could take stuff out, put it back in.
Doesn't seem like it.
Right now, but the truth is yeah, you can. I submit bills and I'm like, I'm gonna do these 20 things, and then like I do 10 of them.
I know, but there's one of you and there's 11 of us.
So let's
Slow-
have
the slow train.
LCB, let's have LCB tell us whether we can or cannot, because we have difference of opinion. So, but for right now, this is the language that we are talking about, and we're trying to take a vote on, and whether we can modify or not. I don't know whether that information is available today, or change it, or remove it.
So we can
have
include,
input from-
if the agreement is to include this now in our draft to LCB, when we get the language out, we'll have an opportunity to do some slight modifications before it's pre-filed in November.
So are you suggesting that this could be totally changed if that is the decision?
If once you can submit this for drafting now, and then when we get the language back, if there is a desire to remove it before we pre-file it, then we can tell LCB to remove it because it's the language or make some changes.
But this is not.
I wouldn't say remove it. I'm sorry. I shouldn't say just remove it. I just meant like you can make modifications to that language.
Correct. You can make modifications, but cannot remove the whole item.
Yes, you could.
You can.
Is that the opinion of LCB?
I would have to defer to LCB, but yes, we have the opportunity to tell LCB, you know, what provisions we would like for our final pre-filing. Right now, we're requesting the language, and then we'll get the language back, and it'll go through a process before we pre-file it.
Let's proceed with the vote. Howard, you have this information. Let's see if you're still a no or a yes.
I'm still a no.
Okay, who's next in line?
Dr. Packham?
My vote is no, and for the record, I'd like to state that that vote has nothing to do with my support for hospital transparency. I support transparency in apple pie.
Dr. Slonim?
Same. I am against this at the moment, but I am for hospital price transparency under the right specific clauses and language.
Mason?
I'm going to vote yes, because I do think this could require some further conversation. And again, it could be taken out, it could be modified. And CMS has a lot of price transparency rules already in place that many of us do comply with, whether it's the charge master and pricing. So I'm supportive of leaving it in because I think we can continue to refine it. And if it doesn't work, and if we're just duplicating something that we've already signed up to participate as a facility in CMS, then I'm good with that too. So I'd like to keep it on and keep it further discussion, because if we remove it, it's the last time we get to talk about it.
Bobette?
Yes.
Sean?
No.
Flo?
No, I believe it should go into a separate BDR.
Okay, Jessica?
Can I guess yes to leave the door open for further discussion.
Yarleni?
Yes.
Dr. Khan?
No.
Okay, and that means we are going to remove it. Okay, and going on to the next provision. It's add a field to existing required hospital quality reports to require parent company and net profits of both the hospital and parent company each year for current hospital reports. Do we want to start with Dr. Barron?
Sure, and I'm a no.
Okay, Dr. Packham?
No, it requires another BDR.
Dr. Sloan?
No,
Okay, Mason?
Sorry, I'm having a little trouble reading the language again there. Can you read it one more time, Sarah, please?
Sure. Add field to existing required hospital quality reports to require parent company and net profits of both the hospital and parent company each year for current hospital reports.
No, I'm not sure. Separate BDR.
Okay. Bobette?
I don't understand the purpose for a separate BDR. I don't understand that. So I don't get that motion. I don't get that directive. The reason that this is actually language that I added based on my 15 years of transparency work in the state. It's very difficult when you get the current quality reports and the hospital quarterly reports to try to look at the organization as a whole. We have 4 hospital systems in Nevada, basically, and they're reported individually, and you can see how much you can see their balances, but you can't see how much money these companies are making. And I think that that's another important piece in the state to figure out what's going on with healthcare in the state. So that's why I'm a yes.
Mr. Chair,
Yes,
could I request that we require our votes and not have them challenged by other commissioners? I'm frustrated by the fact that it's almost like we have to defend our votes. And I think we're entitled to have our votes. I think we're entitled to change our mind. And I think we're entitled to make those changes based on new information. So I'm frustrated that I feel like I have to defend my vote to Commissioner Bond sometimes. It's getting a
no,
little.
so let me chime in. I think I don't see it that way at all. We are all individual commissioners. We have our own views and opinions. We have all rights to change our views and opinions as we evolve with information, more information or lack thereof. So yes, we all have a right to difference of opinion. And that's the way I look at it. So if we change our views and opinions, that's perfectly all right. Another commissioner may disagree with our changing of views and opinions, but when we vote our conscience and our beliefs and our interests and our constituents.
Okay.
So I think I wouldn't take it that way as far as I'm concerned. So we can move on with the vote then.
Mr. Shaner?
No.
Okay, Flo?
No.
Jessica?
No.
Yarleni?
Yes.
And then Dr. Khan.
No.
Okay. Let's go on to this provision. I'm going to read, require a report each year by DHHS that analyzes trends in price, profit consolidation through mergers or acquisitions and access, expansion and contraction, distributed to the governor, the legislature, and the PPC. This report should include all healthcare service categories, hospitals, skilled nursing, long-term nursing, physician, and prescription drugs. I will start with Dr. Barron.
Again, not understanding what the bandwidth of the DHHS is in order to be able to do this. Right now, I'd have to say pending further investigation, I'm a no.
Dr. Packham,
No, this deserves another BDR.
Dr. Slonim.
no, too non-specific, needs additional detail.
Okay, Mason,
No.
Bobette,
Yes.
Sean,
Yes.
Flo,
No, I think it deserves a separate BDR as well.
okay, Jessica.
I'm torn. I want to say yes, but I also think it deserves a separate BDR. So I guess I'll just say yes.
Yarleni.
Yes.
Okay, Dr. Khan.
No.
Okay, now we're going down to all payer claims database. This is the language. Would you like me to read it, Dr.
Yes,
Khan?
please.
Okay, require the Department of Health and Human Services to establish an all-payer claims database of information related to health insurance claims resulting from medical, dental, or pharmacy benefits provided in the state. Public and private insurers that provide health benefits and are regulated under state law must submit data to the database, and certain insurers regulated by federal law may submit data to the database. That is the language. I'll start with Dr. Barron.
Yes.
Dr. Packham,
Yes.
Dr. Slonim,
Yes, I think there's a lot to unpack here, and we'll take a lot of additional info. So I'm happy to support that work.
okay, Mason,
I'm in agreement too. I think this is a good one to keep pushing forward.
okay, Bobette,
Yes.
Sean,
Yes.
Flo,
Yes.
Jessica,
Yes.
Yarleni,
Yes.
and Chair Khan.
Yes.
Okay, so moving on to the role of the Patient Protection Commission. We'll start with the first provision. Further authorize the commission to review reported data outlined in this legislation, monitor patient access, healthcare cost, and systemic price drivers. I will start with Dr. Barron,
No.
Dr. Packham,
Yes.
Dr. Slonim,
No.
Mason, Mason,
Mason, are you on mute?
okay, I can circle back to Mason.
I'm
Bobette,
sorry.
oh,
I'm sorry.
Mason? Mason, we didn't hear you. Are you there?
I thought I heard him trying to get on.
Yeah, I see that he's here. I just don't see him speaking.
He's frozen.
Yeah, he is frozen. Okay, so let me, if you don't mind, Mr. Chair, I'll skip him and then we can go back.
Right.
Okay, Bobette,
Yes.
Sean,
Yes.
Flo,
No, I believe it to be a separate BDR.
Jessica,
Yes.
Yarleni,
Yes.
okay, Chair Khan.
Yeah, do we have Mason on yet?
Yep, looks like it.
I'm sorry. My computer's given out. It's tired. So I apologize. I got disconnected and missed everything there. So
Could you repeat, Sarah, the language we are talking about?
no,
Yes.
I see it now.
Okay, great.
Yeah, and I was a no on this one. So
Okay, and then Chair Khan.
apologies.
I'm a no.
Okay, so we're in a deadlock on this one. I don't know how you want to handle this, Chair Khan. It looks like it's 5-5.
Yeah, normally the chair votes in the end to break the tie, but we are missing one commissioner.
This is Jessica. I'll change mine to a no.
Okay. So what do we have now in numbers? 1, 2, 3, 4, 5. 1, 2, 3, 4, 5 to 4. Is that the count you have?
Yeah, so unless, yeah, so, and Commissioner Flood said she would change her vote to go the other way if that's permissible.
So if that is well, we haven't finalized the decision. So if she has changed the vote before we completed our count.
Mm-hmm. So then it would be a no.
Oh, okay. All right.
Unless-
so let's move
Okay.
to the next item.
Okay, ensure the commission and DHHS has the authority to request ad hoc reports regarding price, cost, consolidation, and access to care. And I'll start
Sorry,
with
could you
Dr.
read? HHS has what, sorry?
Sorry, ensure the commission and DHHS, have authority to request ad hoc reports regarding price, cost, consolidation, and access to care.
Okay, all right, let's go to the vote.
Okay, Dr. Barron,
No.
Dr. Packham,
Yes.
Dr. Slonim,
No, lack specification.
okay, Mason,
Okay, say yes, but with further exploring, please.
okay, Bobette,
Yes.
Sean,
Yes.
Flo,
No, I think this should be in a separate BDR.
okay, Jessica,
Yes.
okay, Yarleni,
No. It
Yes.
lacks
wait, I'm sorry,
No on Jessica.
no, okay, Yarleni,
Yes.
okay, and Dr. Khan,
Yeah, for lack of clarity as to what does it mean specifically at this time, I would be a no.
okay, again, we're in a deadlock then. So it's 5 and 5.
What about AG's opinion on this situation?
We also have a missing commissioner. I think that's a problem.
Yeah, I know that, but we had a quorum, but I need AG to say when we have this, since I have voted rather than to break a deadlock.
So this Attorney General Regat, normally a commission needs a quorum to take action. So if you don't get, a majority to take action. So if you don't achieve a majority, whatever action was being proposed does not move forward. So the way that you're doing this is a little bit different because you're actually suggesting revisions to a document before you make your final vote. But generally you need the majority to get you over the lines. Whatever action you were taking needs the majority to carry, if that's helpful.
So what do we do in this case? We don't have a majority for the proposed language.
For this one, so Chair Khan, I think because you don't have 6 members, and by default on this one provision, we could just mark it as not moving forward.
Is that AG's opinion?
So the AG indicated that we're doing it a little bit different in the sense that we're going line by line on a working document, and we're still needing to take an entire vote for moving forward on this BDR. So we're not there yet. So we're kind of one step before that.
Yeah, so I guess to clarify and to piggyback on what Sarah said, if the motion that the commissioners were voted on were asked to vote on was whether this language should be taken out, then they didn't get a majority to take the language out, so it would stay. But if the motion was phrased as should this be included, then you didn't get a majority of members to say whether it should be included. So
Oh, okay. So then actually this would stay in because I didn't get a majority of commissioners to say to take it out.
So is that everybody in sync on that? Based on the opinion? Yes, we don't have a choice, I guess, based on AG's opinion. Is
Yeah, I
that
believe
your
the
opinion?
motion failed to take it out.
Sorry?
Just Chair Khan, I agree with everything that said. I think it was the motion failed to take it out is what I'm hearing.
Right.
Correct.
So then it would stay in.
Okay, perfect. So then that
Okay.
that clarifies that. Okay. So let's move on to the next.
Okay, and so this last provision here is really a complementary provision for the all payer claims database, and that allows the state agency to develop regulations necessary to implement provisions of this requested legislation. So this is really allowing for the state agencies to develop the regulations necessary to implement this, and specifically giving DHS the flexibility in the all payer claims database. Okay, so I can start with Dr. Barron.
Yes.
Okay, Dr. Packham,
Yes.
Dr. Slonim,
Yes.
Mason,
Yes.
Bobette,
Yes.
Sean,
Yes.
Flo,
Yes.
Jessica,
Yes.
and Yarleni.
Yes.
Okay, and Chair Khan, just for the
Yes.
record. Okay, great. All right, so Chair Khan, that concludes all the provisions of the language. If you want to now consider discussing moving forward with this bill draft, I think that's your decision. And then what we could do, I've taken some notes on some of the suggestions that that didn't make it in, but also highlighted to potentially use a third BDR for or another BDR for. So I don't know how you want.
I'm not sure whether we need another vote to, since we voted on each individual item as is, one way or the other. So I would think that the BDR as proposed with this vote additions of each opinions should stand as is, correct?
Yeah, I guess what I'm asking is do you want to finalize the discussion on moving forward with this bill draft and then entertain a discussion about a potential for another third BDR? I don't know how you want to handle that.
Right, so I think we need.
Chair
Go
Khan,
ahead.
this is Tony Sloan. I'm seeing the DAG's head nodding in the appropriate direction. I'll make a motion to move forward the BDR with the changes that we've just voted on by paragraph line items so that it's clear for the record.
You have a second?
I will second, so Barron.
Okay, so do we need to take a vote and everybody in agreement with the motion on the floor?
Sure, I can do a quick roll call. Should we do that?
Yeah.
Okay, so Dr. Barron,
Yes.
Dr. Packham,
Yes.
Dr. Slonim,
Yes.
Mason,
Yes.
Babette,
Abstain.
Sean,
Yes.
Flo,
Yes.
Jessica,
Yes.
Garleni,
Yes.
Teresa, I'm sorry, actually, then Chair Khan.
Yes. So I think to wrap up, so this motion has been obviously approved also. So here's my concern and thoughts right now. It's almost 2:00. It's unprecedented, but I'm not surprised, as in some of my conversations with some of you had said, if we are able to narrow down these two bill drafts in this meeting without going too long, we've already gone too long. And that's what we have accomplished. There is a couple of other agenda items, and to be fair to all of us, I think we had a lot of question about a third BDR, yes, no. Today, I'm not sure we have the time to even discuss the whole Pandora's box of what should be the third BDR, or what we desire to be the third BDR, or want to be the third BDR in the time constraints that we have. We can always talk about it at the next meeting, but I'm not sure whether that'll make it into the deadlines that we have, because the third BDR will probably have much longer discussion than we had today on these two BDRs, because there's more than a dozen items that everybody has talked about, some offshoots of our discussion today, and some from the previous interest that we have expressed about in subjects of interest to us individually. So in my opinion, I think we should move on, and I think I would like to bring this meeting to a wrap around, unless people are compelled to go on another 2 hours on discussion of what should be a third BDR, if at all.
Chair Khan, this is Tony Sloan. Just a quick question. I thought, so I've had some conflicting information. I thought we were limited, given the time frame, for a third BDR. That's where we've been.
Yes.
I had conversations on that, and now we seem to be saying, okay, let's go forward with a third BDR. I've heard that we should go forward with a third BDR only on the two BDRs we passed, either telehealth and transparency, but now I'm hearing opening up. I just need to know the process.
No, in my understanding, you're right to an extent. Is the idea was if there was a third BDR to come splitting off of these two BDRs, and we are still remaining within the deadline, then we could consider a third BDR coming out as an offshoot of these two BDR discussions. But those subjects are also quite a few. As you notice, a lot of us deferred our votes, yes or no, based on should be a separate BDR, should be a separate BDR, should be a separate BDR. There are at least 3 or 4 in that category already from today's discussion. So we'll never get to anything else beyond that anyway, even if we wanted to or were able to. So even for the third BDR, I don't know time frame wise how much time we have for the deadline to come to a consensus of a third BDR out of the 3 or 4 subjects we thought we wanted a third BDR.
Okay, I just have a question. Is there any way we could have a placeholder for that third BDR? And then I think there is a list of like topics that people said, hey, I think this could be a separate BDR. And maybe we schedule a meeting 2 weeks from now and we go through that list. just throwing it out there. I mean, I think there's some stuff that's good.
So no, I understand that, but even if we meet in 2 weeks and discuss a third BDR, to come to a consensus of a third BDR, Sarah and the AG, the LCB, where do we stand on our deadline? If we start discussion on a third BDR 2 weeks from now, and then have a debate on that, and then come back to fine tune the language in another meeting in maybe 2 weeks, how does that stand out, Sarah and our LCB and other people?
So Chair Khan, we actually have a deadline to submit our requests by tomorrow. So I
Right, but
fully intended.
Could be access.
Time, please.
So
Go ahead.
I lost my thought. So we have to submit our request by tomorrow. And to what Commissioner Flood is indicating, she's saying that we need less detail and is going down a path of having kind of placeholder language. What I will tell you and what I've drafted in our in that last email that I sent out to the commission, I will continuously defer to legislative counsel on their thoughts about how much detail we need. And so I submitted those forms. What we have been sharing right now is a framework for the form that I need to submit to them to hold our bill draft requests. I know that certain individuals, Jessica, have submitted quote placeholder language, but speaking with the legislative counsel, they would like us to follow that form and provide as much detail as we can. If you want to consider talking about, utilizing a third BDR under the 2 topics, as Chair Khan said, you can have a discussion about that. I think I have enough information. I know you all just deliberated on like the role of the PPC and the hospital price transparency being a second or a third option. I feel comfortable if that is the route of this commission that I have enough detail and I could pull those up because it's already outlined in the discussion you had today. So more detail better, but we certainly don't need a lot of detail. We just have to follow that form.
What are we suggesting? If we were to take over one of those, 2 or 3 of those subjects that are relevant to the BDRs today that we have talked about, even if we meet in 2 weeks, we have some language, we have to deliberate on all of that, et cetera, and come with an assumption we'll be coming to an agreement on the language of that third BDR, and then still be in time to submit language again.
No, so I'm saying is that we would submit a request with enough detail. So if you kept it with the 2 topics like we were talking about, and like I think I suggested, looking back at the role of the PPC and submitting a request to have a bill draft related around that topic, that I'm comfortable with that. I'm also comfortable with the hospital price component because that was pulled out of the transparency language that we just went down.
I think I might withdraw my suggestion on that because I think I'd feel comfortable if it was just a placeholder, like very vague. But I mean, we just spent all this time saying this is too vague to feel locked into it. So I don't know if I'd feel comfortable with that.
Yeah, and sure.
You see, that's my concern. I'm still going for deliberation forever in the next meeting. And given our today's discussion, I just don't see us coming up to a consensus at that time. And then what?
Okay.
So
sure.
Really need to make a decision. Placeholder, I understand placeholders have some role in some ways. Sarah, you want to elaborate after you discuss with the LCB? And then my thought was that then the legislature is still meeting and we all have the opportunity to reach out to individual legislators of our constituencies, et cetera. They can always put an addendum or add on, et cetera, to existing bills or others if they choose to and still be there considered at the legislative level.
Yes, so the Legislative Council, although there have been, like I said, individual cases and situational decisions for them to accept placeholder language. That's certainly more of an exception rather than the intended process. And considering that this is a full public commission, I'm not, I think that the discussions that I've had with you and with LCB is really about the transparent process in which we submit these requests.
Yeah, so that's my view. So they have a kind of a reserved opinion on that. The LCB. So anyway, so I think moving forward, I really need to kind of wrap it up before we take the last agenda item of more meetings, and the public comment. So I need to see where do we go from here today. Just leave it at 2 BDRs and look at other potentials down the road in the next few months, etc. As I've been saying before, we have had a lot of other subjects and items and include this down the road. Or we feel that, oh, it's an emergent situation, these potential additional BDRs coming off of this, they're so imperative and crucial to the patient's care, quality, and access that we must definitely do something right now, or else all hell will break loose. So that's my thought, because I'm really concerned about our time. Today has been an exceptional, and I honestly don't feel that it's appropriate for all of us to be sitting here forever in every meeting and every week or every 2 weeks. It'll be narrow. I think we need to take care of what we have at hand, get something in front of the legislature, which we thought was crucial, transparency and telehealth. We have taken that. And if there are other subjects, they can always come down the road. That's my view. But I honestly am very concerned about our meeting timings going on too far. And I'm sorry with all the commissioners, with all their timing going on. But I was afraid this was going to happen today, and don't want to repeat this again. Time-wise.
So Chair Khan, I've got one commissioner with their hand raised.
Yes, please.
Okay, Bobette.
I'm not sure what we're talking about. I lost track. I know a lot of people deferred to on some of the transparency issues for a third BDR, which now is not going to exist. So I don't really know what we're voting on right now. What's before us?
So I'm not. It's not clear to me. I think Chair Khan is asking, and he's checking to see if there is a desire to have a discussion around a third BDR within the parameters of the 2 topics. However, he highlighted the fact that even within the 2 topic areas, there seems to be a lot of discussion. So he's not sure that we even have time to discuss that. Did I capture that correctly, Chair Khan? Did we lose you, Chair Khan?
Hello, can you hear me?
Yes, we can hear you.
So what I'm saying is, I mean, I really feel that we need to stop here in terms of the BDR, because taking another BDR discussion, even as an offshoot from today's discussions, we'll be spending a lot of time. There's a lot of views, and I just don't feel comfortable taking everybody's time for 5-hour meetings or 4-hour meetings, getting into the next 2 or 3 weeks. That's my view. So if we stop here and call it a day and then look at all the other subjects and discussion somewhere down the road, that will be fine, because Rome was not built in a day, and this commission is not going away anywhere.
So,
and by other recommendations for clarity purposes, Chair Khan, you're referring to just a outside of the commission's bill drafts, correct?
Sorry, outside of what?
The commission's bill drafts.
Yes.
Okay. Bobette, I think.
Just like to finish my comment. I think that Dr. Khan, I think thanks. I think that this commission is spending time, but we've got this conflict where we're saying we don't have enough time to do this, so let's not do anything. And then we've got, what you just said, Dr. Khan, that we shouldn't have to meet for so long, but this does take work. So I believe that the commissioners expect to spend time on these things to vet them and understand them. I understand the transparency didn't get as far as I would have liked, but we're making progress. But there's other issues that, we're not spending much time on, and transparency got stuck on some things that you just didn't have enough information about, is my understanding. So I think there's a balance we got to strike. I guess I don't know how to vote on this, but I believe that most of us or a portion of us, expect to spend time on this commission. Because there's a lot. You're muted, Dr. Khan.
Dr. Khan, let me just see. Asked to unmute. Chair Khan?
Yeah, can you hear me now?
Mm-hmm.
Okay, I finally got the video back. So what I'm saying is we need to vote on whether this commission has the appetite to take on a third BDR discussion coming off as an offshoot of today's discussion on one or two items that we were talking about as a subject for third BDR. We can meet again and discuss that while these two BDRs move forward. If we cannot come to a consensus on subject matter in the next meeting to meet our deadline for that language, etc., then that will be it. Is that a reasonable understanding? So we can vote on that.
So Chair Connor, I remind you, our deadline is tomorrow. So we would not have.
No, for BDRs, we are done.
I'm sorry?
For these BDRs, we are already finished the discussion.
Right, the two. So we
There's
wouldn't
two.
have an opportunity to request a third BDR outside of today's meeting. That's all I just want to make sure.
Right, so then it's a moot point. If we cannot request a third BDR outside of today's two BDRs, then what are we going to be discussing in the next meeting in 2 weeks from now?
Well, Dr. Khan, I would really like us to present some of the information people have asked for today to see if when the BDRs come out, there's clarifications that could be made. I think Commissioner Flood, I think Commissioner Khan, I think Commissioner Van Houweling, I think Commissioner Barron, all said that they didn't have enough information or things weren't specific enough. So I think that there's follow-up to do and that I would appreciate us having meetings about. So that
I agree, Babette, with you. We have follow-up to do for sure. But the question I have is for the BDR language to be submitted that can perhaps be fine-tuned a little bit down the road. This is it for these two BDRs. Yes, we can have more discussion in the next meeting, but how does that impact us going forward? Can we add that into these BDRs? I'm not clear that we can do that.
I would totally agree with Babette. I think that the more education that we can get, especially around these huge topics that we've agreed to have in the BDRs, will make us more skillful in making sure the language is right when it comes out of LCB. Because LCB, sometimes they churn out stuff and you're like, that's weird. And that's where we as a commission need to be informed and educated on like how to make that language right. So it's smooth when we do that final vote. Because I would love a final vote on the language going into the November 18 deadline.
And that's why I abstained today, because I'm not sure where we landed. I want to vote on the final bill.
Yeah.
So Sarah, you're saying our deadline is tomorrow.
Right.
Because some of the commissions are saying, no, we want to not meet this deadline and discuss some more. So what happens to this deadline?
So I think what we can propose is you guys decided on both the two BDRs. Maybe if you want to consider requesting a third BDR around some of the provisions that you want more information on, I can request that for LCB and get that language in so you guys can decide on it. And whether we pre-file it or not, and you guys can vote on it, is something that you can consider in the future. So at least let me place in a request for a third BDR around those provisions. That'll give us some language back and you can have a deeper deliberation on it. And then your pre-filing deadline is, I believe, November 18th. And so we have until November 18th to pre-file or not pre-file.
Chair Khan, I would heartily disagree. I believe that we've been told that the process is there's a drop dead deadline. It's today. We offered, when we went into talking about transparency and telehealth as the two prioritized ones, it would be so that we could use a third BDR for other topics and activities we thought relevant to the PPC and the citizens of Nevada. I think using a third BDR when we were told we didn't have access to one and advancing additional items on either telehealth or transparency is just wrong and disingenuous on part of the way we've been led down this pathway.
Yeah, I agree with Dr. Slonim. I mean, I thought we could get more education on the 2 BDRs and like what's going to be involved in that, because I think all the commission members were even saying, hey, we need to focus on the all payer claims database. Like, let's hear about that and the decisions and how that needs to look. So I was just saying, I think there's a lot of groundwork for the 2 BDRs. I'm not in support of a 3rd.
Okay. No, I'm just throwing out different options. You guys can decide that. Chair Khan, I was just telling you there are different options that you can consider, but we would have to.
We're going in circles. We're going in circles. There is a deadline to submit this language for at least these 2 BDRs for tomorrow. Right. Yes or no?
Yes.
Sarah?
Yes, but we have to submit all of our BDRs by tomorrow, Chair Khan. We do not have an opportunity to do 2 and then come back for a 3rd one. We don't have that opportunity.
So we are going in circles on this subject for some time. We need to get to the bottom of this and close this chapter. If there is a deadline to submit the BDR that we have just voted upon extensive discussion after, and that deadline is tomorrow, then these 2 go forward and we don't have a choice. If we don't submit them in the deadline, then I suspect more than likely than not, we lose all this BDR deadline of tomorrow. So we have voted, extensively deliberated on these 2 BDRs, and there's a deadline for tomorrow. We need to move forward and submit these 2 as is. We can debate and get more information from LCB and legals in our next meeting, whether there's an opportunity to deliberate on a 3rd BDR potentially off of these 2 discussions or new subjects at that time. But we really need to get out of this 2 BDRs that we already voted upon individually and individual line by line item and agreed upon by majority votes, and just meet the deadline for tomorrow for these 2. We can always schedule another meeting and by that time have more information whether they will allow us to consider a 3rd BDR before the 18th of November or not. If they say no, then it's a no.
Okay, so
if they say you can, if they say you can elaborate, hold on please. If they say you can elaborate on these 2 BDRs that you have already submitted and consider that, if they allow us for that, then we look at that. Sarah, what did you have to say? Sorry.
So I don't think we're talking about the other 2. I think that discussion has ended, the action has ended, and we're going to move forward with those 2 BDRs. Yes. I think right now, the only thing that we're talking about is the utilization of a 3rd BDR. If you want to use a 3rd BDR, we need to have that discussion now because our deadline is tomorrow. We do not have an opportunity to meet again past that deadline. So I have to submit a request by tomorrow. There's no waiver for us.
Let me narrow this down. We have 2 scenarios. If we have to have a request for a 3rd BDR today, correct?
Yes, if you want to request a 3rd BDR.
Okay, if we want to, so let me narrow this down, please. I'm getting to a point we need to wrap it up. If we have that option, we have to decide today that we want a 3rd BDR. We have 2 scenarios. One, to vote upon whether we want a 3rd BDR relevant to these 2 BDRs, as we have discussed by some commissioners, or we want to have the other BDR on a totally new subject without going into the individual subjects. So I would call in for a vote that do we need for the 3rd BDR to discuss the offshoots from today's discussion of these 2 BDRs related to those, yes or no, or we want a 3rd BDR on a totally separate subject, which is again a whole Pandora's box, as I've said before. So maybe we start with the vote on discussions from today. Do we want a 3rd BDR request put in as an offshoot of today's discussion of telemedicine and transparency? And the answer would be yes or no, we want more 3rd BDR related to today's discussion. Let's take a vote on that.
But that means we're going to have to stay on the phone from now until we finish that, right?
No, we're just taking a vote. Yes, we want a 3rd BDR based of these 2 offshoots. And we already know the 2 or 3 items we've talked about that people were interested in going into a 3rd BDR related to transparency and otherwise. And that's my concern. We can go on forever discussing those 2 items. So do you see what I'm saying, Tony?
No, I'm confused. I'm sorry to be so slow on this, but
Sarah, you can clarify that, please.
Yeah, let me defer to our DAG to explain what we are permissible to take action on today in relation to our bill drafts. Attorney
Okay.
Ott?
Thank you, Sarah. Went to the language of your agenda, and what it says is for possible action, discussion on commission work plan and possible bill draft requests. Subbullet A, finalize bill draft requests and language for submittal to Legislative Council Bureau related to telehealth and transparency policies. I don't think that under that language, you are allowed to discuss a third bill draft request. So I think you have agendized the two items that you have acted upon. And all you can do under this item is talk about a work plan to consider further options in line with what Chair Khan had said of, contracting personal legislatures and opinions about other bill drafts requests. But I don't think that you have the ability to commence discussion of a third non-agendized bill draft request under the agenda that has been posted.
Okay, so does that answer everybody's concern? That's a legal opinion, so I don't think we can go beyond that. So technically that would close the subject for today's meeting. Is that correct, Attorney General?
Correct. Like I said, there is a possibility of trying to talk about things in the future, but since your bill draft request is tomorrow and you only have two agendized, you can't bring up a third one today.
And that's been my thought. So thank you for that clarification. So I think the subject is pretty clearly elaborated by the AG. So from that point of view, I think I would like to close this discussion because once a legal opinion is on, it's a legal opinion, not any one of our personal opinions.
Dr. Khan, I have no opinion on that topic. Done. I agree.
All right. So
just a comment.
Basically, if anybody has an opinion opposing the AG's advice, then we can say so. Otherwise, we'll just move on.
Yep. Just a quick comment, if you wouldn't mind. In anticipation of this agenda, I actually proposed language for a third BDR that was omitted we appropriately agendized an item on workforce that was left off because we were told there was no BDR, a third BDR going forward. And now we hear that if we would have agendized it, we would have had an opportunity to discuss. So I'm concerned about how the agenda made its way through. We talked about the fact that we were doing two, we did two, and now we're talking about a third. And there are important topics that we've let go by when we could have had a bill draft request opportunity to get executed here, and that's just disappointing.
Okay, so I think we're all learning as we are evolving and proceeding in this whole process. So I think, but I appreciate your comment, Tony. So moving forward, I think I need to really move on to the next agenda item before I fall apart and half of us start collapsing here without food or just maybe alcohol during this meeting. So having said that, I think our next agenda item, I lost track of everything here. Hold on just a second, please. Discussion of potential agenda items, I think is our next one. For future meeting dates. So I had submitted two dates that was asked of me, specifically October 12th and November 30th. Others had not given a specific date except their days that they are preferable. Majority thought Monday was okay, some thought they did not. So any comments on the next meeting item? We met on October 12th. Sarah, logistically, timelines, etc. Where are we with that for these two BDRs?
I'm sorry. Can you? I'm confused as to what you're asking about the.
So asking for next meeting dates on the agenda item. That's what we are on.
Okay, so if you're talking about what our next deadlines are, as soon as we submit these requests, we are really have to wait for LCB to give us back language so we could potentially make some slight modifications to it before the pre-filing deadline. The pre-filing deadline is November 18th. I'm pretty sure that's accurate. It's November 18th.
So if we met on October, then hypothetically on October 12th, which I believe is a Monday, That'll give us enough time for LCV to come back with whatever their corrections are to the language for us to find.
I can't speak. Yeah, so that's what I'm trying to say is I can't speak on behalf of when we're actually going to get that language. That I have to wait for LCV. They don't have a deadline to us as to when they're going to give us back the language after this request. We just have an obligation once we get the language to pre-file it by November 19th. Or 18th, sorry.
What I would suggest then is as soon as you get that information from them, perhaps notify all the commissioners that that information has come in and ask for the commissioners' availability for the next meeting.
Chairman Khan, I disagree with that, Chairman Khan. I just think we should set those 2 meeting dates now so we have time to schedule that. And we will use those meeting times to review the BDR language if it's ready and to work through some of these other issues that we have not had time for if it's not ready, but at least we've got the time protected. Because if we start over with scheduling in 3 weeks, we're not going to have time for meetings. And it seems like we have 2 good days.
That's perfectly all right with me. So should we narrow down to our potential next meeting date that is reasonable for everybody in 2 to 3 weeks?
Yes.
My personal thought is make it 3 weeks after today. I want it after 3 years.
So are you proposing, are you proposing October 12th, or let me look at the dates? No, that's sooner than that.
That's about a little over a month from now, but we can make it 3 weeks if we have to, or 4. Hopefully we'll have some information by then.
Yeah, the 12th is 6 weeks away, so it would be better if we could do earlier.
Yeah, the 21st is good for me.
Yep.
The 21st of September. Okay. And then I would be remiss if I didn't bring up Commissioner Bohannon's request that Mondays are good with her, but she would prefer to do it in the afternoon. So if there is an appetite to entertain an afternoon meeting on Mondays, that is something that she's requested.
I think I respect that, but I think at the end of the day, we need to poll all the commissioners and see who's available. To my understanding, all the initial polling, everybody else said mornings, and Monday was the majority who said that. So if that still remains the polling time for the 21st of September, then unfortunately that may not be feasible to move it to the afternoon if the majority want it in the morning on that date.
Okay.
So, all right, so having said that, trying to wrap it all up, we have talked about that. Any public comment requested here or not?
Okay, so are we closing out this? So are we going to, just for clarity, Chair Khan, so September 21st at 9 a.m. is what we're aiming for?
Yeah, I think we'll ask the commissioners to get back to us because I want everybody doesn't have immediate access to their commitments on that day or time.
Okay, great.
So I think I would appreciate if in the next couple of days, if all the commissioners could please send your availability to Sarah so that we can start planning on that. So let's go to the public comment. Anything in the north?
Okay, hold on one moment. So those of you who are still with us and attending, if you'd like to speak in public comment, please go ahead and raise your hand now. And if you're on the phone, it is *9. So I'll pause for a moment and just allow those to indicate whether or not they want to speak.
Do we have anybody in the north?
Chair Khan, I don't see anybody raising their hand, so I don't have any public
testimony. Anybody in
testimony.
south? Anybody in south? Do you see anybody, Sarah?
I don't.
Okay, so I really, honestly, truly, from the bottom of my heart, appreciate all the input, and I really, truly apologize for this prolonged meeting. I really mean that because I never expected in my life I will sit in a meeting from 9 a.m. to 2 p.m. continuously with a 5-minute break. So I'm sorry, but I think we accomplished a lot moving forward. As I said, so we'll meet hopefully next time around and try to contain it. But again, everybody needs an opportunity to speak their mind and soul and come to some consensus. So again, my apologies to everybody. Really deeply apologize, but hopefully next time we can have a better, shorter meeting. Is there a motion to adjourn?
So moved. Tony Sloan.
All right. Any opposed?
No.
All right. Thank you very much, everybody. Thank you very much. Appreciate it.
Everyone.
Thanks.
Thank you.
Bye.
Thanks. Bye.